right?
And, yep, you
I heard
won't,
you.
girl, you
I heard
won't.
you. I know, and I haven't even read. Ooh, I think this is
Right?
nice. A little Stanley Flats. No, no. No, 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 no.
I said they
Alcohol
brought
is
peanut
not
butter
becoming
whiskey
in
for
on
our
the
coffee.
table. Are we started?
Not yet.
Oh, thank God. Let me read for a minute. You guys are gonna do your own bios? Because I know all of you. I'll talk about you.
Okay, you
I
can
have
talk
no
about, you
problem.
can talk about us all you
You can
want.
do it.
Yep.
Yeah, that's good.
Because I do know it. I know you too.
Okay, do it.
Remember, we're still 30.
We're still friends?
30.
And 30.
Oh, we're 30. Oh.
All right,
That was a
we
long
are
time
gonna
ago.
go ahead and get started.
That was a long time ago. And I was even sassier back then.
I can't imagine you
Exactly.
sassier.
At 30, oh, I was out of control.
Is your computer muted?
You were looking
I-
at the peanut butter whiskey bottle.
I've thoroughly enjoyed my life in Las Vegas.
How do you know?
Should it be?
Yeah, just mute your computer.
Mute.
No, that's like, I don't know.
I assure you.
If you
know how to
guys
do it.
have some background or echoing online, let us know. We'll
I'm
try to
impressed.
fix it on our
Food
end.
stuff in here. It will get that way, but
She might have to come up and figure out how to shut it off.
I do have echoing, there's echoing.
not mine. I didn't do it.
Yeah, this is the microphone, but I'm looking.
Thanks, Lord.
What is it on Teams?
Do you have yours up? You don't have a presentation up, right? You don't have a,
It's not
Teams up?
connected. No, I don't.
it's fine to me. Somebody's got echoing. Maybe Roberta, change your settings or lower your volume, or is there somebody else
Where's
in the
Trish?
office that has it on?
We're gonna have Trish come and try and.
All right, go ahead, Ann.
Okay. Well, howdy. Welcome to. Oh, as I fall over. Don't trip on the crack.
Oh, please don't.
It's on the floor. Oh, yeah. Would that be work comp?
No.
Yeah,
Yes, definitely.
tripping on.
It's 5 o'clock somewhere.
That's right. Welcome to NDPC. We're both on Teams and in person. Glad to see you guys. Thanks for showing up. Thank you for attending. This is how it's going to work online. Everyone is muted. If you have questions, please raise your hand. Christy will be monitoring it, and we'll ask the question out loud. Of course, it's an open forum. If you guys are here locally, just catch my eyes. I'll say hi, and we'll get you to talk. Those of you guys online, Christy will call you out. We ask that you always be kind and respectful. Even though some of us, including myself, is extremely sarcastic, it is not appropriate in this setting because not everybody can see your face, so your sarcasm might be lost. No calling out names, no specific companies, no specific people. I think that was directed at me.
Probably.
I think it was. We couldn't do it without our board. So grateful to have it. Christy Bybee is still our president. Vice president is Trish Gibson. Secretary is Catherine Nelson. Treasurer is Sean Ellis. God bless him. God bless him wherever you are, Sean.
Thank you.
God bless you. Directors are Sue Hare, Nicole Marley, Varushka Corso, Dalton Hooks, Trudy Johnson, Kevin Campshire,
Where's Kevin?
Kevin Depashard.
Debbie
Debbie Parshad.
Every time.
Because there's too many vowels. Miguel Delgado and Glenda Lee Jackson. Don't forget our website. You can always go to www.ndpc.com. Get all our information. If you are a member, there's also a members only group. Welcome to have it. We'd love to have you as a member. So if you want to be a member, please go to the members and sign up. We do have our 3rd annual gala coming up, and invitation and registrations have been sent out. Christy, have we sent out for the gala?
Yes.
We'd love to have anybody who'd like to also show off your name as a sponsor. As well, we'd love to have you go. Remember, it is a formal event, not necessarily a themed event, but it is formal. The sponsors of this event is Hooks, Ming, and Clemens, and we so appreciate it. He allowed us to come in here and what a lovely place he has. Oh, and then our panelists today. So today we talked about what we were gonna do and we're always trying to figure out new things. If you guys want a particular topic, email it to us so that we can get it back and we can look at it, work it, and put it into the rotation. First, we have Reggie Summers, who's at Paradigm. And Reggie and I were talking about it because we met like in 5th grade, in 1902.
Just yesterday.
Just yesterday. Yeah, she was reminding me that I'm 30 still, so I love that. And she's an incredible nurse. And when I say that, it's not just because she works for Paradigm, which obviously does all the CAT claims and has the level 10 billion with regards to complication. But she also is someone who understands our process. We were joking about the fact that she's done it all. She's been in the work comp side of it. She was a claims manager for a company. She's done it all. So she understands where you're coming from. If you have questions, you can't quite get it to fit into work comp or how it works, Reggie's the girl. She's the one to do it. There's Dalton, the Hooks, who apparently is all. The Hooks, who apparently is the all. I heard something the other day about his fiefdom here being up to 100. I appreciate that because that's someone who's here to fight for us. We have legislation coming up, we have all that stuff coming up, and now with him and his enormous group, we really actually have some representation. He's divided among 17 other places, so it's not exclusive, but again, it's somebody who understands. He is now the largest defense firm here in Las Vegas. And again, he goes back, I don't think he goes back to 1902, but I do think he goes back to like 1963. So he has absolutely, like Reggie, been around for 100 years and looked at all the things, obviously grew up at SIS before it was called that, went on to OSHA, and then decided to conquer the world. So we so appreciate you and always your knowledge. And then there's Cody, who I just got to know this last couple of years. Cody's also a nurse, another
Where's
notes and you don't have any paper, if you want, I'll bring it to you.
That's not what you want to see. Sorry, I don't work on PCs normally, so.
Sorry, he said it's a PowerPoint.
Not even.
There it goes.
Oh, there we go.
Well, I just needed my presence.
I
It's
saw
my-
it.
you to walk in?
It's my juju. It's
All right.
So now you guys go. So can we go back?
No, we're good. Yep.
So we're gonna discuss the basic terminology that you're gonna need to see in physician reports, and I think Christy is gonna send these slides out to you, just so you know. So, yeah. And when it might be beneficial to get a nurse case manager on to help you kind of weed through some of the medical jargon. And now we're not working again? There we go. One more. So I started with imaging. By the way, you can't. Yeah, there you go. So there's lots of different imaging that physicians order, and I just wanted to give you a basic of why they order certain imaging. X-rays, it's a 2D image. It's quick, it's inexpensive. That's what you're going to get first most of the time. The most of the information you're going to get.
Hold on one second. It's not transferring to this, so can we pull it back? Take it not in,
You need fresh data.
not in, sorry. There you go. There you go.
Is that up?
That's how we have to do
Is
it.
it up now?
Yep.
And I don't know if you can do full screen or not.
You can't do full
both,
screen
you
on
gotta-
here
you gotta
because
choose
it
one or the
won't,
other.
it's not transferring. to
Got
this.
it. So X-rays are 2D images. They're quick, they're inexpensive. They're going to give you a little bit of information. Most of the information you're going to get from X-rays is about the bones. Is there a fracture? Is there something that we can see that's out of place? You'll see requests for flexion extension X-rays. Those are not typically done at your concentras or your first visit or at the ER. The flexion and extension are typically ordered when they're wondering if there is some slippage in your discs, or in your spine, and we'll go over that a little bit later, but there are specific X-rays that might be ordered to give you more information or give the physician more information. A CT scan is a 3D image. It's a little bit faster than an MRI. It's more detailed than an X-ray, so it gives them a little bit more information. And so it gives them more information in complex forms for the bones, typically. Although it can see some other soft tissues, it's not as much information as an MRI. The MRI, it has no radiation, so that's good. You get patients that go and they've had 33 CT scans, they're being exposed to radiation every time. And so sometimes they'll get an MRI. We do have the benefit of no radiation. It does show the soft tissue and the bones more accurately. So it gives them the most information. The only time you'll see CT scans, you'll be like, okay, they had an X-ray, they had an MRI, why are they ordering a CT scan? A lot of times they're doing a CT scan if they've already had the other imaging when they're preparing for surgery. They may need a little bit more information and they can plan their surgeries and their surgical approach based on the CT scans. So don't be surprised if they ask for a CT scan later in the process, especially if you're getting ready to go into a surgery. Yep. And so I just wanted to show you kind of what those images look like. So you can kind of get an idea why a doctor might order one versus another. You guys will have access to these slides, but here's your X-ray, basic information. Here's your flexion extension. They're looking at the angle of the spine to see if anything is slipping forward or backwards. And then you've got your MRI image and your CT scan. So you can see the CT gives you more than the X-ray, but not as much as the MRI. And so there are specific reasons that a doctor is going to ask for one or the other, and it's usually because they need a little bit more information. So these are the things that I wanted to talk about. Sprains and strains, partial and full thickness tears. We're going to talk a little bit about dermatomes, bony injuries, cartilage, spine terminology, and then some just ankles, hands, wrists, knees, just to try to get you a little bit of basic information for each of those areas. So a sprain and a strain, they're used interchangeably by a lot of people. They are not interchangeable. They may use sprain/strain when they don't know where the injury is. So a sprain is going to be a ligament injury, and a strain may involve a muscle or tendon injury. And of course, from the outside, we may not be able to tell right away which one it is. So that's why you'll see it sprain and strain. The thing that I see a lot is later in the claim, 1 year, we're a year or 2 years later, and well, I only accept it for a sprain strain. But now we know that there are tears to ligaments or muscles or other injuries that have occurred. And one of the pushbacks that I get from the physicians is, When you accept a sprain strain, you're accepting that there may be injury to the ligament, the muscle, or the tendon. So later, when I tell you it's a tendon tear, you can't say I'm not covering it because it is a sprain strain only, right? Now, the physician has to relate that. They need to know that mechanism match. The physician is their job to say that tendon injury or that ligament injury is related to your claim because. They should be giving you that information. It's okay for you to question. Just because they have a tear does not mean it's mine. That can be true as well. So, but it really is up to the physicians.
Yeah, so Dusty and I were, Dr. Kia.
Yeah, can I add a little bit to that?
Sure.
100%.
Sprain and strain are pretty imprecise words, right? As it's used in the medical community, it doesn't mean much, right? The way it gets used is something is wrong with this muscle, but I don't have something more specific. So if you say arm strain, okay? There are a million muscles in the arm, there's a million ligaments, there's a million tendons in the arm. In other places besides Vegas, the doctor usually narrow down the diagnosis more once they're more certain, right? So what started as a forearm strain may turn into medial epicondylitis or golfer's elbow. That's a better diagnosis that's more specific. But if you don't know at the very beginning, you can't call it that. So you just start with sprain or strain. The problem is sometimes the diagnosis never changes out of sprain or strain. But just for y'all's education, it's a very imprecise word. So don't be surprised if it changes later on, because hopefully it means someone had a better answer. Thanks.
Yeah, so, thanks, Doc. Dusty and I were, Cody and I were talking about this just before the presentation a little bit, and so historically from the claims side, this has been a problem, a game of cat and mouse. And when I started doing workers' comp when I started at CIS in '89, you had claims that would be accepted for left arm, right arm, leg, head, and over the years, through litigation, as claimants' counsel became more aggressive about asserting, well, you've accepted it for the entire leg. You've accepted both of the legs. Adjusters had to be more savvy and more precise in what they accepted in order to prevent a legal creep of what's been accepted as part of the claim. And so the discussion we were having around this strain thing is that sometimes adjusters will stick to their guns that it's just a strain that I accepted it for, and sometimes that may or may not become problematic. It is my position. Obviously, I'm biased. I'm a defense guy. I don't believe in whining. This is why I don't represent the other side. I literally am not
not always say, it should not always stay sprain strain. You should get to a place. Now, on a claims perspective, I can see why you don't want to accept all of those diagnoses, because they may or may not be related to your claim. It could be just an underlying pre-existing, and we need to have the doctors help. That's where your case manager can get in there and say, okay, which one of these diagnoses is related, so that then they can make a determination if they want to change the scope to include a better diagnosis.
I'm gonna add some to that for you administrators that are out there. Your D30 is based on, the D30 is your notice of claim acceptance. That's based on the diagnosis you see on the C4. That's appropriate. That's appropriate. And you have to get that out depending on what house you live in. It might be in 5 days, it has to be by 30 days. What you have to consider with what these folks are saying is there are times, most of the time, you're going to issue an amended D30. And that amended D30 is going to be issued because it isn't a strain. It's actually a herniation. It's a tendon tear. It's a whatever. If you do not issue that amended NOCA or the D30, and you start treating and whatever, when you get to the end of your road, you're going to file that D35 and they're going to go, hail to the no. No, you said it's a strain, and now you've got tear, you got this and this and that. So you have to make sure that you as an adjuster and an administrator are following those diagnoses. And if you're not, shame on you, shame. If you see something when you're following it and you're like, wait, time out. We had a cervical strain and now all of a sudden we're talking about shoulder pain and all of that stuff. You have to investigate why, because what they're saying is the body part creeps. And so it might have been a cervical strain, but really it wasn't. It's a rotator cuff or something like that. Watch the diagnosis. You don't have to accept the diagnosis because you love it. You just have to watch it. And if it's accurate and it's related, then okay, I gotta take it. You update your D35 cards, you do all of that stuff, and you get it on. Now, here's the other part. Maybe it's not. Maybe it's all those other things she was saying that are horrible. Make sure you say, I am not treating la. And you have to make sure that you deny what you're not going to treat or amend your NOCA that you are going to treat. Okay.
Yeah, and I just put this in because I feel like this is an area that is a high problem for the physicians, it's a high problem for the patients, it's a high problem in litigation, and it's a high problem for the adjusters. So I just put it in there so I can maybe give you something else to think about when you're looking at that, because this is almost every claim.
It's a lot of them, and I'd like to add that, we talked about the ones where it just stays a sprain strain. And so again, I can't represent the claimant's arguments or their position. I'm wired the way that I am. But when I see a file where it is, claimant comes in, they have vague description of an injury, the doctor diagnoses them with sprain strain. I've never seen a single report in 22 years of practicing on this area where a doctor said, I actually don't see anything wrong with you at all. A sprain is probably the minimum that they're going to give for the reasons that Dr. Keok outlined. And if that diagnosis doesn't change, there's some indication there that this is a problematic claim. That's a red flag, right? Because there's nowhere for the doctor to go. Somebody's got something going on that either maybe it's just, there are those cases, we have those videos where people lay down on the ground and claim that they were injured. And they got vague symptomology.
If a doctor legitimately keeps it as a sprain strain for a year, and they've done all the imaging, they've done all the testing, they've done all the things, and it's still a sprain strain, unless they're not updating their note and they're not paying attention. But if they're saying, yeah, I don't see any other diagnosis, then you have another route to take. That's an indication too. So there's just a lot about it, and I don't want to stay here too long, but I wanted to just get you thinking in a different way. Where are the challenges that are coming from all the different directions? Because none of you are wrong. It's just a different way of seeing it. And if you see all sides, maybe having a more direct conversation with your doctor. Why is it still a sprain strain? Do you think there's anything else, or what do I need to do next? This is another one, tendinitis versus tendinosis. A tendinitis is short, acute. They can see it on imaging. They can usually say, there's some fluid there in that. There is something that just happened. That's more likely yours. A tendinosis, is that they've had some chronic inflammation, they've had some chronic partial tears, they've had some stuff that was there pre-existing, and you can have tendonitis on top of tendinosis, right? And so again, in this state of litigation that we have, just because they have chronic issues doesn't mean it's not yours. From an acute injury, somebody who has chronic tendinosis is more likely and more susceptible to have an injury during an acute event, because they aren't starting from 100%, they're starting from 50%, so they're more likely to be injured from something that maybe the mechanism doesn't feel right to you. So getting your doctor to clarify, is it tendinosis or tendinitis, might give you some indications of which direction you go. Is this mine or not?
It also will make you be able to look at your 617 scheduled occupational diseases. They include tendinitis, etc. Scary place to go, because if you ignore it and it's actually a tendinitis or something like that that does qualify under scheduled 617, that's a whole different world. 617 is occupational diseases. It's not injury. So if you get into that and people are looking at that, tennis elbow is my favorite, epica, da la la la. That one, it's scheduled. So if they diagnose this, it's scheduled. It's not something you go, oh, maybe, maybe not. It's a scheduled diagnosis. So make it pinned down and then make sure you're aware of what's on the schedule. I couldn't pull my note because I got my phone.
That's all right. So yeah, and so I gave you some pictures too, kind of what that looks like from that standpoint. I think so, yeah. Partial tendon tears versus full thickness tears. A partial tendon tear means their tendon is damaged, and I think the best way I ever heard this explained, when you see muscle or tendon ligament tears, we all want to think it's linear. I took my shirt and I put a cut in it, or I put a hole in it, right? It doesn't look like that in the human body. Your muscle fibers, if you looked at them from the crossways, think of spaghetti noodles, hard spaghetti noodles. They're all coming out there, and that whole thing, bulk, makes up that muscle. You can have a partial tear where just like this little section is shorter than the rest of it, but you still have 3/4 that's holding on, right? Maybe we need surgery, maybe we don't. A full thickness tear means it has come completely away from the bone. It's usually retracted. That's going to be acute most of the time. Doesn't mean they didn't have underlying tendinosis, that they didn't have frayed edges, that they didn't already have a problem there, and your acute injury caused that muscle to just no longer be able to hold on. And so typically in a full thickness tear, they can tell on imaging if that's old or new. There's going to be fluid in there. It's going to be retracted. If it's retracted and atrophied, then you know that that probably was already there, and it's really just about getting your doctor to say whether or not this is an acute injury. You can find a full thickness tear that's not yours, and you can find a full thickness tear that absolutely 100% is. Dermatomes, radiculopathy, paresthesia. How often do we hear this, right? All the time. So it's really imperative. One of the things that I like to do as a case manager is I'm going to pin that patient down quickly. I need to know not only where does it hurt, really happening. There are a lot of things that come into play there. So getting that clarity early will keep it from, I mean, unfortunately, I mean, you see it both ways. Either they are faking it because they just don't want to work and they don't like their life and they have something else happening. It happens.
No.
Or they don't understand how to be clear. So they are not getting the best treatment if we're keeping on a spray and strain and we're trying this and we're trying that and we're not getting clarity for 6 or 8 months. Their life is impacted. That's not fair to them either. So I think our job is to get clarity as quickly as possible. And if I can't do it, you need to have the physician do it. I need to step in and go, I need clear information, doc. I need to know what we're looking at so that we can get the right treatments authorized. They're not going to blanket authorize everything you want because you're hunting for a solution. I need to get some clarity, and the first part is looking at those dermatomes, especially when you're looking at radiculopathy, because it gives us information. So dermatome, these dermatomes, you can look them up online. They'll give them to you. You can keep them by your desk. There's a lot of cards that are available that show you kind of where that should be. If they, by the same token, have say on the leg, I don't know if I put the leg up there. Say on the leg, they are, I have sciatic pain. I have sciatic. Anybody who has anything that goes down their leg and they don't have a high IQ for medical, it's sciatic. But not everything is sciatic. If it's coming into the groin, it's a different thing, right? Now, say we've got something on the imaging that is an L2, L3, and they're complaining of pain going down the back of the leg. Just because it's on the MRI does not mean it's yours. And it doesn't mean it's the thing that's causing them pain. We have to be clear, and so early getting that information is really your best protection for you and the patient.
The first 90 days of your claim is not the time to shop at the dollar store. Just keep that in mind. The first 90 days you need to make sure that you are absolutely exploring all of everything so that your diagnosis is solid.
I love you.
I'm just
Well,
saying.
the faster that people get the right diagnosis and the right treatment, the faster everybody wins.
Yes.
This is not just about saving money. Of course, we want to avoid unnecessary treatment. We want to avoid unnecessary PT. We want to avoid unnecessary surgeries, right? That's helpful for the TPA. But think about that patient. They are sitting at home waiting 3 or 4 or 5 or 6 months with no answers. They're miserable. Their personal life has been affected. They can't earn their income. They now can't pay their bills. Now we have financial stress. It is unfair all the way around to not get to the best doctor as early as you can, to get the best treatment and the right diagnosis so that you have a plan. Everybody wins. The claim will save money and the employers get their people back and these people get back to their lives. It really is the best of all worlds. Spend that time up front. Find out what's happening.
So from a legal standpoint, just to drop in a couple of things. Yeah, look, the claimant on the C4, this issue with whether we're getting good information. Number one, this is why the C4 and the C1 needs to be filled out by the claimant, by their hand, so that you don't get things lost in translation by a supervisor who's writing down what they were told. And where I've seen this area come up as a big problem is when you've got an injury to the lower extremity, you've got a Hispanic patient, and they say, I hurt my foot. Well, we're going to accept the claim for something related to the foot, and then months, years later, it is, I didn't mean ankle. I said foot, and that includes the ankle. Well, that doesn't include the ankle for native English speakers. And so you may not even know that you have this issue until something comes along later. So we have to make sure that when you have folks that are not native English speakers, because words aren't the same, Eskimos have how many words there are for snow, and the same thing is true in the reverse. We have fewer words to describe problems. So you just want to make sure, just from the employer standpoint, that you're getting out of the way, let the injured worker tell you in their own words what's going on, and then be sensitive to the idea that things get lost in translation. And I agree with the idea that you want to find that out sooner rather than later, right? It's going to be worse if you find out later.
Yeah, because we will have wasted time.
I feel like radiculopathy is probably one of the most misdiagnosed things that you see from doctors, and half the time the doctor's not even touching the patient. So let's say if they're even were vague on their symptoms, the doctor doesn't touch the patient, he just listens to them. He doesn't check their reflexes, dermatomal sensation. Half the time they'll just be like, low back hurts. Okay, that's radiculopathy.
Right.
Maybe to expand treatment or something. But
And we do see bad actors on all sides, right? I mean, let's be honest. There are adjusters who absolutely will not budge. I don't care what the imaging says, and I don't care if you probably have that before. I've seen doctors who want to add everything that's ever. Well, I see a chance for a surgery. I like surgery. There are bad actors who will just see something and go for it. There are patients who knew they had a problem, but they didn't seek treatment for it because they don't have personal health insurance. There are bad actors, but we cannot always act on the fact that everyone is a bad actor. Sometimes we just, I always say it's not good news or bad news. It's just news. Just tell me what it is so we know what to do next. I'm going to get the information. I'm going to get it clarified, and then I'm going to hold everybody accountable. I mean, at some point, if you're giving him the best treatment and you're giving him the right thing, if the doctor's not doing what he's gonna do, what he's supposed to do, it's gonna show. If the patient's not showing up to PT and they're not giving good, accurate information, they're changing their symptoms every visit, right? That's gonna show. If the adjuster is not budging or allowing the treatment that needs to happen for us to clarify, that's gonna show. We have to just know that there are bad actors on all sides, and we can't assume that they're all bad actors, because sometimes they just, maybe it's just missing in translation. So radiculopathy then will follow those dermatomes, but it's a pain that starts from one place and goes somewhere else. Almost all the time it's going to be related to those spinal nerves, right? So you're accepting for a shoulder, the shoulder's what's hurting them. They're maybe not lying, but we've done all the imaging in the shoulder, there's nothing on the shoulder. But if it was a mechanism of a twist, or they fell and hit their shoulder, right? And no one's looking at their neck because their neck doesn't hurt. They didn't put the neck on the C4. They didn't, but it's in the back of the shoulder blades. Well, at some point when the doctor says, okay, I think it's the shoulder, that's what they hit, we do the imaging, they do therapy, nothing's helping, but the pain's isolated in that dermatome for that C4 or 5, whatever, they're gonna go, I think we need to start looking, I think we need to look here. And so you can do it as a rule out, you can protect yourself as an adjuster, but we have to get the information. If there is something in that cervical spine, then a different conversation needs to be had. If it meets the clinical correlation, right? What they're saying matches to that possible diagnosis.
Your job is a
Concentra does them, everybody does them, ER's gonna do them. X-rays quick, easy, and gives you some information. So I just give you some information on different fractures, and I want you to see what that looks like on an X-ray. I mean, obviously, this bone is not where it's supposed to be. It's a problem. This one, the bone is still where it's supposed to be, but you can see a fracture line, and they're hard. Sometimes there are what we call occult fractures. They're not seen in that first imaging, but if you give it a day or two, it will become more evident, so you might need repeat x-rays. And so they do clarify pretty well in radiology what type of fracture you're looking at. Obviously, if you're looking at a comminuted fracture, that means those bone pieces are not only not in line, but they're separated and there's little pieces, and so that is going to cause you to have a more complex recovery. So just looking at that type of fracture, look at the type of fracture they're given to you. Obviously, typically fracture is a trauma. You know what happened, you know it's yours, and so just getting the right kind of physician. Get an orthopedic now. Do not stay at Concentra for 3 months. Do not stay at your occupational clinics. If you see a fracture, get them straight to an orthopedist. That's going to save you money, save you time. They're going to give you the appropriate treatment, and you're going to move forward.
30 days.
I don't even give them 30 days. Listen, I come on, I'm out.
Yep.
You pay for a visit either way. Get to the right specialty fast. Get the right diagnosis, right treatment, and you're going to have a better outcome no matter what. I put in a separate area here for spine fractures because those can get really hairy. We can see, a spine fracture is not a spine fracture is not a spine fracture. Depending on where it's at and how it really will greatly change how it's going to be treated. So you get end plate fractures. That's where you have the tearing of the vertebral body on both sides. That's usually a degenerative condition exists already. Those are weaker there, but a trauma can cause problems for a weak bone a whole lot faster. It would take a much lower mechanism of injury to create an issue for somebody who already has some degeneration or some osteoporosis, right? Transverse process fractures, that's this little piece that sticks out at the back. Those typically are non-operative unless it's completely dislodged and now you have a ligament injury because there's lots of different things that hold those together, right? Those typically sound really scary. I have transverse process fractures of 3 or 4 vertebrae in a row, and it sounds pretty scary. It's actually not. Get them the right treatment. Get them to somebody who can say, I don't need to intervene here, or I do, and then get them the right therapies, get them some pain management, and then you're going to be good. So they're not as scary as you'd think, but that does mean that they had a significant mechanism of injury. Typically, a transverse process fracture requires some compression, requires a hit, and so you have to also be thinking, not only am I treating the bone, but there are a lot of muscles and tendons and ligaments that are attached at those areas that were fractured, and if you have enough mechanism and enough force to fracture 4 vertebrae, you got to know there's going to be some lingering issues with getting those muscles and tendons and everything moving back in the way that they're supposed to. And then compression fractures. Again, compression fractures, the docs can help me in this, but I typically see compression fractures in somebody who's a little bit older, doesn't have great bone health, maybe they're morbidly obese, they've been putting a lot of pressure on their spine for a long time, they don't actively exercise, so those muscles are kind of weak. They may be osteoporotic, which means their bones are getting brittle and tender. So compression fractures may or may not require interventional treatment. They may or may not be yours, but I think that they have come a long way in imaging to be able to identify if that's pre-existing and was already there because they can see some callus formation and they know it was already there, or if it is acute because there's fluid signal in those imaging.
Can I just say something?
Yeah.
After this class, can we get a certification for a minor in nursing?
Look, I tried to make it simple, but give you just something. These are the things you're going to see, right?
This is good.
No,
Yeah.
it's so good. I know.
Sorry, I had to.
No, I appreciate you. I appreciate you. So, if you we can always do one that's just on spines. Like, we could do a whole class on that. I just wanted to give you just some basics to start to think a little differently when you see the notes. I have a compression fracture. That doesn't mean it's yours. It doesn't mean it's not. You take people as they are. If you hire a morbidly obese 50-year-old who's done manual labor for their whole life, and they don't eat well and they don't take care of themselves, and they have a fracture that wouldn't have happened to somebody else, I'm sorry, that's yours. You got to take it because that's how you hired them.
Yeah, usually they'll specify like age indeterminate, or they'll say non-acute on X-ray.
Yeah, they've gotten pretty good at seeing it on the imaging. So again, get that imaging. Pay for the imaging. Get it early.
The technology with CT could even show that it is an old fracture. Because they can remove all of the muscle in the spine, allowing you to see if it's an old fracture or a new fracture. They can tell.
Right. And so get your imaging. Pay for that imaging early. Get the information that you need, and then hold your doctor accountable. Is this new and acute, or is this old, or is it acute on chronic? There was already some problems there, but now we have an acute issue, and I can tell because. And so then you just have the information. Now you have a choice to make. Am I going to accept that, or am I not going to accept that? Because the treatment's going to go there no matter what. So knowing early for everybody's benefit is how you get this information, get it clarified, know right away.
Uh-oh, hands up.
Hands
We're all
up.
in trouble.
Oh, here we go. No, I'm just, for those not here, I'm sitting in the back, so that's why they're making fun of me. You own it. You can't, you have to look at that. When you buy someone, when the employer hires them, they own it. That's the hardest conversation to have as an administrator. Yes, they have a screwed up jack back, but
You hired them.
you hired them. And you made them a lifting blah, blah, blah. So yes, that's what you get. So that's a hard conversation, but unless you can clearly establish that the night before they were in a bar fight or something like that.
Which
it's
does
yours.
happen.
It happens, yes.
It happens.
It absolutely happens. But when you see that, just consider most of the time, if you're aggravating it, you own it.
Right.
You also have to think about the mechanism of injury, because you can
Yes.
have a young person that has a compression fracture. If they fall, if they're up or they
Yep.
fall straight on their butt, that can, they can get like a thoracic.
Or if they are struck, I have one right now with a hydraulic. A hydraulic came down and got him. We have 4 levels of fracture. We're looking here because that's where the pain is. That doesn't mean that sometime later we're not gonna. I mean, a compression fracture can happen to a young, healthy individual with the right mechanism. You have to know what that looks like. And again, get the information. Hold the doctor accountable. Is it mine? Is it not? Be clear. Tell me why. And then you have to make your decisions because the treatment's gonna go there no matter what.
Okay, we're already at 1 hour, just FYI, you're gonna have to talk a little faster.
Go faster.
A
Well,
little
some of these I'm not gonna have to stay on. So I'll go quick. How do they tell what's yours and what's not? Again, they're looking at bone marrow edema. They're looking for acute signs that there's something new that just happened. They're looking for avascular. So it
still doesn't mean that that isn't gonna come back and show its ugly head. So it is a really ugly thing. So even if you've got a compound fracture and you've treated it and everything looks
And they
good,
went back to work and everything was great.
just word of caution, have that in the back of your mind that that could rear its
You see
ugly head.
osteomyelitis, get your information quickly. Get to a good ID, get to a good orthopedist, find out where that and know whether or not your original injury could have resulted in a bacteria getting there.
I have a comment online, Nicole. Do you want to unmute and ask your question?
Not a question, it's a comment. Just to all those adjusters out there. You guys hear me okay?
Yeah.
Okay.
You know we cannot hear you back here.
They can't.
Okay, wait, they can't hear you in the back. Hold on, I'm gonna turn up my volume, maybe that'll help. Go ahead.
So all you adjusters out there and anybody that's handling a claim, if you have a diagnosis of osteomyelitis, you need to pull all of the fire handles in your office. You need to contact your adjuster, your supervisor. You need to rally the troops because that is a very big diagnosis and it's a very nasty situation that can get really bad really fast.
So she said, if you have a diagnosis of osteomyelitis, you need to call all the troops. Reach out to your supervisor, reach out to everybody. That's a nasty diagnosis. It could get very ugly, and you want to get everybody on board.
Yeah, it can go into sepsis and that can be fatal. So it is something to take very seriously.
We got hands clapping.
Nice.
All
All right. I just did some basic terminology in the spine. You're gonna see these all the time. Spondylosis means that somewhere in that central canal, that in between the bones where your spinal cord is, it is shrinking. Now it can be from inflammation, it can be that you're getting some arthritis and there's just less space for that. Spondylosis just means there's a central canal stenosis. You've got reduced space for your spinal cord to move. Okay? You've got osteophytes. That just means that your bones, your disc isn't as cushy as it used to be, and your bones are starting to react, and they're going, ooh, we need some little more cushion here, so it's building more bone. Well, bone's not cushy, right? Now you got less space in your foramen. You've got other issues that are happening. Spondylolisthesis means you've got some slippage, one way or the other. The bone on top of another bone is either moving forward or is moving backward because it's just not in alignment anymore. Increases your risk of, that means it's unstable and they're at risk for spinal cord injury and worse effects if you don't handle it. That's when you're usually, when they do those flexion extension x-rays, they're looking for whether or not that spine remains stable when you're leaning forward or leaning backwards. If it's not stable, they're gonna go for a fusion every single time because they need to stabilize that spine to protect your spinal cord. Annular tears, I always liken it to, the disc is a donut. It's a jelly-filled donut in between your bones. And when you've got annular tears, that thing has been cushed and cushed and cushed, and there's no jelly coming out, but along the edge you're starting to see cracking of the bones or cracking of that donut on the outside edges. That's at your annular tear. That denotes that there is some sort of degeneration that has been happening, and that disc has been under pressure for a very long time. Typically that's a chronic thing, but it can become symptomatic when you're injured. So you've got a disc, if you've got the donut, jelly donut, and you push it and a little bit of the jelly comes out the end, and then when you let go of it, the jelly comes back in, right? That's your bulge. It's there, and depending on what movement they're doing, depending on, sometimes it comes back in and sometimes it doesn't. Your body can resorb a disc bulge and it can heal without surgery. It does not mean because you have a bulge that you have to have surgery. But people don't understand that. Something's bulging, I have to do it.
With them every day. And
Every
no
day,
clue.
all day. The herniation is when we've squished that donut just enough that that jelly is out and it is not coming back in, no matter what we do. And now it can be compromising your spinal roots. It can be compromising things. And so there are a bulge is not a herniation, is not an annular disc tear. They're all different, and I just wanted to give you some information on how you can kind of see that differently. So if you've got that going on, get a case manager on it, get the doctor to clarify what's yours, what's not, and here's why, by that mechanism of injury and the new symptoms they have, if it's yours or not. If you aggravated it, it's yours. If they have a terrible back and they are lifting 50 pounds and they just twisted the wrong way one time, guess what? You own it. So figure out what it is and move forward. SI joints. This is another area where it can refer. The SI joint is where your sacrum meets your iliac crest, your pelvic bones, right? It is, you see way back here. It refers pain it's one of those shoulder neck things. Is my shoulder pain from my neck, or is my neck pain from my shoulder because the muscles attach? SI joints are very similar. You have to have a good clinician who does the right testing to determine, is my pain the low back or is my pain SI joint, so that you get good information, good treatment, and you're moving forward, right? So I just put it there
And
so you can.
sometimes they may do injections
To identify whether or not it's your SI joint or your lumbar.
So that doesn't mean that,
Or
you're
hip.
picking up the SI joint or the low back, but
You can do it as a rule out.
They do it as diagnostic to rule out something. So if they do ask for it, and maybe you're like, well, wait a second, I don't have the low back, I have the hip, or whatever the case
Yeah.
may be, then just tell them to write in their dictation, like, hey,
I'm
I'm
ruling
doing
out.
this to rule out something as a diagnostic procedure.
You getting up, Ann, or no?
No? So your hip, your SI, and your low back cross over a lot.
I like to say rule out under medical investigation to really protect.
Sure.
you.
Yes.
Exactly.
But it's important that you go that way, because if you don't, and
You
you
own
say,
it.
no, we're not gonna do it, or whatever, you're gonna go down the road and still not be diagnosed with the right thing or anything else. So when they come to you on that rule out, do it. Do it.
Do it as a rule out. Protect yourselves from I don't do your job, so I don't know what you need to do. But if they're
Write a
asking, it's
letter.
because the doctor is trying to clarify, what problem am I having here? So he might need to do an ESI in the lumbar spine. That doesn't get better. Well, maybe I might do an SI joint injection. Maybe I'll do a hip injection, or I'll do imaging at the SI joints, or imaging at the low back or the hip, because it all crosses over. You have so much that crosses over. They're trying to clarify and give you a right diagnosis and a right treatment plan. So holding it up is not helping anyone. It's not helping you. So that's why I threw those in there.
Excellent.
Ankles are the worst. They take forever to heal, and even 5 years later, you have one sprain and your ankle's never the same again. I just wanted to give you a little bit of information. You know, we've all heard carpal tunnel. Tarsal tunnel is very similar. It's just that there's there's one little space that these nerves have to go through, and if it gets inflamed around there from soft tissue, if you've got a bony injury, if you just sprained it or stretched that just right, you're gonna have, and it's very similar to a carpal tunnel. You find you have tarsal tunnel, and that's your diagnosis, and they've clinically diagnosed it. It matches the exam findings. It matches your EMGs or whatever they've got. Just do the release. The longer that repetitive motion only. Negative does not mean they don't have carpal tunnel. That doctor should know. Get to a good hand surgeon early and then trust them. And if you don't trust them, go to one you trust and get a second opinion. But carpal tunnel, when it's handled quickly, is usually a very quick recovery. It's inexpensive. I don't think it has a high value in your PPD. So get it treated, get it done, and get out. Otherwise, you're going to compress that nerve for a very long time. You're going to sit on it for 6 or 8 or 9 months. That nerve's going to continue to be compressed. Now, even if we go and do the surgery, the symptoms are going to last and you're never getting out of it.
At Health Center of Nevada, we're doing invasive carpal tunnel under ultrasound, and it gives you detect carpal tunnel, and they're now doing it in the office at a lower expense. But we are going to have October 16th.
Nobody can hear you online. You're gonna have to scream a little louder. We don't have a
On
microphone.
October 16th, we're having a free testing for people who have carpal tunnel to see if they have it. Just so
Okay.
you guys can see. But there's
So-
other ways too.
Yeah, and so just make sure there is a dermatome that it has to match, right? So we're looking at that clinical correlation. Does what they say match with what the doctor's giving you for a diagnosis? Make sure that it fits that dermatome. If it doesn't, it's probably not carpal tunnel. And there are unscrupulous doctors that will do carpal tunnel on every single patient. It may or may not be yours. It may be pre-existing. It may have become symptomatic. But either way, get the diagnosis, get the information, clinically correlate it, and then know that that EMG may or may not matter. They don't mind doing it, but it's a lot to put through, and it's expensive to put. It's expensive and it's painful. If you haven't had it, especially if you have an irritated nerve, whether it's positive or negative, you're going to go forward with the surgery anyway. So just really determine whether or not you need that information. Do I need $1,500 in another 6 weeks of delay when I can clearly see that the correlation is there? There was a mechanism that fit. They have the right subjective complaints. We have the right diagnosis from a doctor clinically. They're showing the right exam findings. You got to decide from a claims perspective if that's worth your fight.
Trish has a question.
And you need a job description so the doctor can correlate to their job.
Well, if they're looking at a chronic, yes, but if it's an acute injury and they can say, you know, you got a bus driver, I've had it, bus driver, had an accident, smack their hand on the thing, and then they're going, carpal tunnel, you're a driver. I'm not covering that. And so we show the video to the doctor and he says, right there, that's where it is. It hit that, and right at the right space. There's a mechanism that's sufficient enough for me to say, clinically, I believe that it's related to this injury.
Well, I think it's very important to distinguish that, as Ann said earlier. You can have carpal tunnel is one of the ones that's a little bit unique. You can have an injury under 616, and you can have an illness under 617. And to Trish's point about the 617 part, for those of you who went to the DIR conference last week, you had the NIOSH, the guy from NIOSH, who was, I thought, a great speaker, and I confirmed with him something that I've been teaching since back in the days when I was with OSHA. The number one indicator as to whether someone is going to develop carpal tunnel syndrome or not, according to NIOSH, is job satisfaction. It is job satisfaction. It hasn't changed in a couple of decades. And so I'm not saying that carpal tunnel syndrome as a disease is psychosomatic, but there is a problem with, I have never seen a carpal tunnel syndrome occupational disease case that I didn't think I could defend and win on, because these cases are very specific. You get carpal tunnel syndrome as a disease when you take a human being and turn them into a robot. That's what happened at Tyson Chicken, which is where all of this kind of came from in terms of an OSHA. You have a person that is cutting a thigh. this is what they do.
And
All
it's
day.
number of repetitions, it's the number of
Correct.
days that you do it, there's, I mean, but we're seeing, I personally am not seeing a lot of people claiming carpal tunnel from a chronic exposure. What we're seeing are the traumatic carpal tunnels. And so it's hard to make that switch in your brain if you don't know. They can have carpal tunnel that was really only, once every few weeks they get, a little hand pain. They put some muscle rub on it. They put some ice on it. They're good for a while. They probably have it. But now we've had an acute injury that for some reason, like I said, I often see it, a fall on an outstretched hand, or they're getting struck by something. And if you've got an inflammation in an area where there's already not enough space, treat it. Get to the right doctor, get it treated, get moving, and you'll be in and out quickly, and it saves time and money for everybody, and they're happy because they got it taken care
Doc
of.
had a question or comment.
Yeah, so I do EMG, so I kind of know
Yeah.
a little bit more about it. So EMG, the big thing with EMG is it's snapshot time. Like if I didn't do an EMG before the injury or after the injury or right after the injury, it really doesn't give me a whole clinical picture, but it will give me that snapshot time of how they need.
You started out speaking very.
We can't hear you. They
but
can't hear you,
now
I
you're
assure
thinking
you.
too hard.
Get a
You
little
have
bit,
to
little bit
speak.
louder.
Are we going
Yeah.
for them? So the nerve, if it's injured, it won't show anything on EMG for the first several weeks. So if you get that within the first several weeks, it won't, but it will show stuff after probably 3 weeks, 2 to 3 weeks. And so I'm able to see that and able to understand whether or not that was acute or chronic. And there's also other options other than surgery, although surgery can be very beneficial in the short term. You can do bracing at night, and you can do injections, and those are things that I do as well. There's also other ultrasound guided procedures.
And EMGs are you have to understand, EMGs are very subjective. It requires, if you get a really bad EMG, administrator who went through a course and they don't really understand what they're looking at, it is very subjective in how it's correlated, correct? How those images on that little screen show them.
It's unfortunate it's that way because there's a lot of practitioners that don't do it well. And
That
so
don't do it
even
well.
If I see another one, I'll probably do another one because I'm like, I don't know how they did it.
Right,
So you really have to find somebody.
and they're expensive, they do hurt for the patient, they're painful, so I'm not saying don't use an EMG, they can be very, very helpful, but they aren't the end all be all that everybody thinks they are. It's not like an MRI is gonna show you this or that, like you just need to know, clinical is much more important in these diagnoses.
We got standing Ann over
No,
there.
I was just, yeah, standing in. I was just gonna say traumatic carpal tunnel, absolutely considered non-traumatic. Get an IME, get something, look at it. Because if you look at the Mayo Clinic and a lot of the large clinics, they show that non-traumatic is hormonal old women. And so I can say that because that's what I am. I'm a hormonal old woman.
Misogyny much, Ann?
Right. So just make sure that you are, if you're looking
Alright,
at
next
carpal
one.
tunnel, investigating, and we gotta keep moving on.
Yeah,
We got
I'm getting there.
32 slides and we got.
No,
10 left.
I'm almost out.
Okay.
Dacre veins, just know that Dacre veins is very similar to carpal tunnel, but it is a different part. If you see a Finkelstein, I will just tell you, you see a positive Finkelstein, and what they've done is it's right in this area here. Dacre veins is right here. So it's very close to that carpal tunnel, but it is a very different tunnel. So if they say Finkelsteins, they're gonna have them close their thumb and stretch that nerve. If that pain is right there in that anatomical, in that first compartment, you've got a Dacre veins, and they're gonna treat Dacre veins. So clarifying whether it's carpal fall on an out. Pain and inflammation and they're having problems with supination and get to your hand surgeon. Get a good diagnosis, know what you're looking at, know what the treatment is, and you will get out faster. Everybody will be happier.
Okay, we
I'm
have
almost-
to take a break.
We gotta
You
take a
have
break?
10 slides left.
Yeah, but they're not that big. We can pass.
You said 10 minutes ago.
I know. Can we take a break?
Yes.
Okay, everybody go to the bathroom, get some food, get some coffee. We'll
Listen,
be back
I
at
like to talk.
10:30. 10:30. See, and we only have an hour and a half left, and we still have 2 more to go.
I said, I could sum mine up in one. Just call me.
Nobody wants to hear legal terminology, so it's fine.
Dude, that's
Just
gonna be
look at the
exciting.
slides.
I'm excited about that one, honestly. We do have lots of raffles, so if you guys want to buy raffles tickets, they're up at that front desk. I'll meet you there. Lots of raffles today. Joy, you're freezing and I'm gonna be sweating.
Should I go re-up?
You have to realize I'm in my little office all day. Heat control.
Oh, nice, nice. Is that so you do? Yeah, I just was thinking.
Or let me give you another one.
Because
I did element too, so you can smile. Oh, yeah, that's all the.
Oh, good, good, good.
super informative. I'm hoping we can get a couple of slides.
Yeah.
Because for me, what I keep seeing, there's other folks like me where, like even the attorneys, we get new attorneys, but they have no background in workers'
And so
comp.
because the doctor threw it on our note, now we're asking for scope expansion to everything.
And
That's not fair
when
either.
you guys were talking about, I mean, I had a million questions, but some of my stuff, I don't wanna get you off topic.
Dusty, you are on this call,
But
mute
like-
yourself.
When you have an injured worker who English is a second language, now you're talking about medical and legal stuff, so these are all.
And they don't
things-
understand.
No, and even as a, native English
Identify
speaker,
it
I
quickly.
don't understand the medical or legal stuff.
Identify your barrier and then fix it.
When I'm teaching.
And if the attorney has to send an interpreter, because they're not going to do it, then let's do it.
Hey, Christy.
I need a Spanish speaking doctor, let's do it.
Christy, tell Dusty. Oh, she's not here.
No, I hear you.
I'm grateful. I really, they're like, can we have some
And I can't pause it. If I stop it, then it cuts the video off.
I really do.
I think she was over 20 years. She's been a Right, yeah, and she's been with GRM for like 4 years. I haven't been here, but she's
summarizing something I could have read their own stuff. Like, why the fuck did I pay for something I didn't get so
but if you share that
Dr. Boudet.
Oh, man.
Like cockeyed this way. All right, guys, they're gonna give me 10 more minutes to get through, and so I'm gonna blow through knees and shoulders fast because the most of what you do is knees and shoulders, and I did give you some information in the slides. You'll get those so you can go through them. I'm always happy to answer any questions later, but we're gonna go real fast here. Knee injuries, I think the biggest thing for me, I mean, you've got meniscus, you've got ACLs and PCLs and other ligaments, and then you've got chondral injury. So just know what they're treating. If you have somebody who has severe arthritis and they have a meniscus tear, it's because they have severe arthritis, whether there's acute findings or not. And if you got a doctor who says, I'm going to go in and do a meniscus surgery on somebody with severe arthritis, you are wasting your time. You're putting your patient through a surgery that's not necessary, and I would get another opinion. So that's really my big thing on knees. Chondromalacia, that means they already had pre-existing problems. They have some softness in the cartilage of their knees, and when you hear that they're going to do a chondroplasty during surgery, basically they're going to open up the knee and they're going to do a surgery. They're like, while I'm there, I'm going to create some micro injuries in hopes that the body will, natural mechanisms will be initiated so that it can start to heal that. It's silly for me to already be in the knee to do surgery and not address this problem, whether or not it's yours. So just know what a chondroplasty is. They're making micro holes in that cartilage in hopes to bring your own blood flow and healing properties into the knee. Shoulders, you've got tendinopathy. Those rotator cuffs are not well, they're not happy anyway. You got 4 muscles that come into your shoulder. And if you've got, you again, it's thinking of the spaghetti, right? You might have some partial tears. It's not always the healthiest. It's not maybe 100% holding on. And now a different mechanism can cause an injury that maybe it wouldn't in a very healthy person. So just know whether or not you have a tear. Just know it's not like cutting into your shirt. A partial tear can heal without surgery, and the best surgeons will tell you so. If they automatically say there's a partial tear, I have to have a surgery, that is not the right thing for the patient, whether they like it or not. Sometimes we protect them from themselves. You get an unscrupulous doctor that says, we have to go straight to surgery because there's a tear. That's not true, and it's not always the best thing. Sometimes it is on the other side, but it is not necessarily true. And so, let's see. I just wanted to hit this. TBIs. If you have a brain injury, I just wanted to give you kind of, it used to, everybody called it a concussion, right? They still use the word concussion, but it was changed formally to a mild traumatic brain injury. If you had an injury to the skull and the brain inside, you have a brain injury whether you like it or not. If they called it a head contusion, a head injury, you probably have a TBI. And so don't be afraid of that diagnosis. It doesn't change anything. If you have a mild injury, they're tough to find. The MRIs may or may not show it. If you don't have a bleed, you're going to have a lot of behavioral issues. You're going to have a lot of, you need to, the best thing I can tell you is get to a good provider quickly. I'm going to say something that's going to hurt people's feelings here. In Chicago, brain injuries are not handled by neurologists. Period. End of story. I'm used to having Loyola, Northwestern, these big companies or these big medical systems, and they are not treated by neurologists. They are treated by sports med. That is not the case here. They go to neurology, and neurologists are fraidy cats, and they want to know for sure what they are or not dealing with. You are going to get an MRI, VNG, VEP, EEG. They're going to do testing because that's how neurologists are trained, and that's what they do. So if you are going straight to neurology, I would opine that maybe you'd be better with a sports med. And if anybody's got one of those medical groups here, get me a sports med who treats concussions, and I will take my patients there. Let's do it. Get a good doctor who understands brain injury quickly. More than anything, you have to intervene. If they start to have maladaptive behaviors, it happens between 30 and 45 days. They start having problems with memory. They start, instead of admitting it because they don't want somebody to think their brain's not okay, imagine that you hit your head and you think you're okay, but now you can't go anywhere without glasses on, or every sound makes you frustrated, and now you're angry all the time, and your personality has started to change, and people are saying to you, that thing barely hit you, you're fine, right? It's frustrating. They start to get a maladaptive behavior. Now they have interpersonal relationships with their boss, with their family members. It is a mess that you don't want to go down. Get them to a treater that is doing the right thing. Do not let your head concussions stay at a occupational clinic at all. Get them out and get them out quickly to a provider who understands brain injury. We do have a few here in the city. I can't give names because, if you want to ask me about it later, I'll tell you.
4
But,
minutes.
4
minutes.
Yeah, that's right.
Damn, she really got the
That's it.
Oh, we
She's
got
jumping.
2 more.
She's jumping. So I am not going to go through these, but there are different things that you're going to see on imaging. If you see something on imaging on a brain injury, you are in trouble. Get treatment now. If you got a midline shift, you got a major problem, and it's going to be a problem moving forward. That means you have a moderate or severe brain injury, and you're probably looking at some level of a permanent disability. Get somebody on, get a nurse who can get you to the right providers, and get it treated quickly.
Cody, you're my hero online.
Can I just say real fast? Instead of neurology, we very rarely work with neurology. We work with PM&R physiatrists.
Yep.
Those are the best treaters for TBI.
So, hey, come on, let's go. And let's see. I did go through some injections. So, your MRI findings, I put them there. I'm happy to go through with, later. The only thing I will say about injections is, because then I'm done. Injections are treatment, yes, but they are different. Look at the type of injections your PM&R is asking for. Sometimes it's an epidural, sometimes it's a facet block, sometimes it's a medial branch block. They all do different things. They give us information, so just know that a facet block is looking for pain at a bony joint, where a medial branch block is blocking the nerve that goes to that little joint. So they're asking for you think, well, we've done 5 sets of injections. This is ridiculous. I'm not paying for any more. Make sure you're looking at what type of injection they're asking for. Make sure it clinically correlates and that they're getting the information and providing it to you after each set of injections. It helped, it didn't help. Because it helped, we're going to go to this injection. Because it didn't help, we're going to go to this type of an injection. They're trying to identify and clarify down to the right point. There are doctors who will do injection after injection after injection and give you no information. I'd stop those ones fast as I can, because you are putting your patients in jeopardy every time they do an injection that's not necessary. So make sure you're looking, and if you have questions about what type, get the clarity from the doctor.
Quick caveat, it's important to also tell that there's diagnostic and then
therapeutic.
Diagnostic.
Yeah.
So
Yeah.
you're gonna have like.
We hope they're diagnostic and therapeutic. We hope they're going to give us a result, but they may or may not, and that doesn't mean they failed. It means that they gave us information to move on to a different pain generator. So just make sure that you're getting clarity. Have your case managers get clarity. If you don't understand why they're
top right.
Hey Monica, hold on.
It's not sharing right now?
You have to share the screen, you have
So
to go
where-
back, oh, in the Teams.
Yeah,
So
where
go
is Teams?
right here, go right here. I think.
That's Word.
No, no, there's a, see the black and white thing here?
Yeah,
This
that's
thing?
what I don't know because I don't use
This.
PC.
This.
There you go.
So,
So that you want to select that screen and share it.
but I think I have to go back
Go to your
into Teams
NPC right there. Now click share.
and then click share.
Icon.
And then it'll be the screen and then you'll find the one in here.
Right there.
Windows.
Cap-
Here, is it this one?
Yeah.
It should be that one. Oh, it's on share here.
Yeah, gotcha.
I can't see it.
That's
And
okay.
then if it gives you grief, you can do
There we go.
control
Hold
F1.
on.
And it'll let you, you have to do control.
All right,
F1.
we're gonna get started.
Alt.
Yeah, F button. Sure.
Did that mess it up again?
I don't know.
Put it back to where it was working before.
Yeah, she's never been able to have it in that mode and have it actually work.
Really?
Nope, that's because we had it in. It can't work in. It doesn't work in presenter mode, which I don't know. I don't understand.
Well, now I don't know. Hold on.
We can just go back to PowerPoint now.
Okay, so go to PowerPoint.
Share screen and you can toggle over and get it to show
Yeah.
that.
Is it, which one of those is it?
The other way too.
This one, I think?
Yeah.
No?
Then it could be like, and if they say something like,
One on the far right.
This one? This one?
is it on the screen now?
Yeah, it is now. It is now.
Not the full screen version, but the version where it shows the thumbnails on the left.
That's fine, I think.
I think that's where she had it before.
If you want advanced forms,
See, will it move?
Go to the next slide and see if it's.
Yeah, it moved. I got it too.
Yep.
Okay, I have no idea.
I just don't work on a PC anymore, so.
And this is brand new to me, but it's a lot nicer than my other ones.
Fair enough.
Thank you, wonderful.
we were trying to do an erase, so the teacher took it, you were fine.
Think you're up.
All right, you're up, go.
Hello, everybody. I am gonna talk about, really, it should be who you gonna call, and the Ghostbuster theme song should be playing till it sticks in your head, because you should just call us, that's it. And that's the end of my presentation. After Cody, I'm like, I can't follow this. So I'm gonna talk about case management and when to call us and what we do. So case management is, usually they're a nurse case manager, we're registered nurse, we come from a different kind of, or a wide range of experience in medical disciplines. We use this knowledge to be able to map out a road to recovery for that and support that injured worker so they can recover, return to work in some kind of a life in an optimal amount of time. This knowledge also helps that injured worker have smooth transitions from one level of care to the next without fracturing their care and increasing their odds of recovery. We also have that ability to refer that injured worker for immediate care. When we see something, we either do it or we contact you guys and let you know what's going on so that they can.
It won't move. Yeah, you gotta take it off the slideshow.
It's not on slideshow.
It's not?
No. And it
It's
did move
here,
previously.
it's here, but it's not there, so just FYI.
Uh-oh.
It's online, so it's just not up.
Okay.
Sorry, Reggie.
That's okay.
Reggie, I think you're gonna have to just keep
Keep
going.
talking?
Just keep
Keep
talking.
talking,
Yeah,
all
just
right.
keep talking, yeah.
So case management's kind of a collaborative process. We assess, we plan, we facilitate, we care coordinate, we assess them again, and we advocate for this patient so that, the treatment options, so that we can also try to find the best care for that injured worker. We also have to kind of take their family into consideration because these injuries, and I deal with catastrophic injuries, so they're pretty traumatic and it affects the whole family. So we also have to take into consideration all of those effects and what happens with the family dynamics. We are a resource between the healthcare providers, insurers, adjusters, attorneys, injured workers, and their family. We are the boots on the ground. We get to be able to wear eyes and ears so that we can report back to everybody. So we assess the patient's needs. We collaborate with all the doctors to devise treatment plans, schedule appointments, and ensure that all relative stakeholders are properly informed. We educate that injured worker and their family on relative health issues. Most of our injured workers, most of our population in our society has so many comorbidities that will affect the healing and the outcomes of their injuries. So I'm constantly finding out, I'm talking about their blood sugars and their diet and their exercise and are you taking your medications? Because when a diabetic will always tell you, my sugars are good. And you test it and it's 350. So they're not. We also evaluate the whole person, their family dynamics, their support systems. We don't just support that or treat that injury. We have to take care of the whole person. We're also that patient's advocate to ensure that they get the best care and they have the best outcomes. And let's go to the next slide. So when is the right time to bring in a case manager? We would say immediately.
Right away.
Because statistics show that if you may have to pay a little bit more upfront when you bring one on immediately, but in the long run you'll save money. We can always start at any time in the claim process, but like I said, experience shows that with engagement, information, guidance, it will also reduce your costs.
And your case managers that are worth their salt, if they come in and they go, you know, because you don't know, maybe it looks like a really terrible injury, and you go, oh my gosh, we need a case manager. We get in there and we go, you know what, your guy's going to be okay.
Yeah.
You got a good treating provider. The patient seems to be compliant. Everything looks like it's going to be okay. It's okay, and we are not going to be heartbroken if you say, thank you so much for your help. I don't think I need you anymore. I think I can handle it from here. We can always reopen later. We can always help later. We can always answer. So getting us in there early, we aren't going to hold it if we don't have to. We're not going to spend your money if we don't have to.
And you can always just call and go, hey, this is what I have. What do you think? And we'll be honest. So you can always call. All companies are supposed to have a workplace safety program, and they take it seriously, but injuries and accidents do happen. When that happens, a complex injury occurs, that injured employee or injured worker often needs the support of someone to explain the medical procedures, help them develop, or understand their treatment plans and guide them through the recovery. Injured workers and their families, they're overwhelmed when this happens, and they're confused and they're scared. So, and most people don't know how to navigate the work comp system, so we can all, between the nurse case manager and the adjusters, will help them through that little bit of recovery.
And may I ask you a question?
You can.
So I'm a novice to this,
Okay.
so pardon the remedial question. So a nurse case manager is part of the insurance company? No? So they're separate?
I'm separate.
Okay.
Here's how I explain it.
Okay.
I always say, like, I don't work for the TPA.
Okay.
I don't work for your employer. I am hired by them because they're the ones with the money. Right?
Okay.
So they're the only one going to pay me. Your attorney's not going to pay me. You're not going to pay me, right? The only one who can pay me is that adjuster. So I don't work for them, though. My job isn't to come in and green light whatever they say. My job is to come in and be that advocate, be that I'm going to gather
cases. I don't want
The doctors are telling us the information, but 99% of the time they're not explaining it to the patient. We're the ones coming back,
To
educating them on what that's gonna look like, here's what you need to know, and so
And just for your
we're that help.
information, these two ladies work for separate companies, Paradigm and Eagle One, right?
Yeah.
But there are nurse case managers that work within a TPA, and those are telephonic nurses or even field case managers, but they work within that TPA. So there are two
Yeah.
different
Yeah.
kinds,
There are.
right? So there's
But the concept
external
is the same.
and there's internal. Concept is the same,
Concept is
true,
the same,
yes.
correct. So additionally, if there are any problems related to the injury, a nurse case manager can help identify them. We also make sure that effective medical care or medical progress with that injured worker is being made, so we can kick them in the butt a few times. Also, to alleviate any problems, we also, in concerns, like Cody has talked about, there are some bad players, and we also identify that and go, heads up, this is what we need to do, and kind of get that quickly to a different physician. And for physicians, case managers are very important because we facilitate that communication. We are the ones that can kind of push through some of the authorizations a little bit quicker, we get reports quicker, and also helps kind of keep costs from escalating.
So
Okay?
get your gatekeepers to let us through, because we wanna help you.
I just wanna comment on that real quick too. When we have a nurse assigned, if there's an attorney, I always allow my nurse to CC my contact at the attorney's office, so we're black and white on the case. It resolves the case much sooner, you're avoiding unnecessary second opinions, IMEs, litigation. It's black and white. This is what I'm getting, here you go.
You're getting to a point that I wanted to make, and that is that there's another person involved in this, right? And it's going to be claimants counsel, a lot of whom are hostile to the idea of a nurse case manager being on the case because, while you two have rightly said that you're a patient advocate and you're not adversarial to them, many of defense counsel or claimants counsel believe that you are.
Correct.
So I'd like for you to address that in terms of experiences that you've had and maybe how you deal with that when you see it. And
The
I know
no
you've got a question
contact.
about it.
Yeah, I just wanted to know, I mean, by the time it comes to the impairment rating, I feel like most people really like their nurse case manager. And, you know, as far as what I've observed is just the outcomes are better when the nurse case manager's been involved. You know, I've not heard one person say that they did not like their case manager.
That's great.
Once in a while, you'll find that, I haven't heard that very often, sometimes
It
they
depends
do
on
when
how
you-
they're coached on the other side. If,
And
if,
Or what they're hiding.
yeah.
There we go, next slide.
And the attorneys have found the value because the claim keeps moving, the nurses
Correct.
keep it going.
And honestly, for the attorneys in the room, I don't take it personal. I don't care. You don't want me to talk to your client? Fine. I won't talk to your client. I can tell you it's gonna be 10 times harder. They don't understand it because now no one is educating your client.
On medical, right.
No one's educated. The doctor comes in and says, here's what we're gonna do, and then they go, the doctor said they're gonna do this thing. And I literally had a severe arthritis that needed a joint replacement, and the doctor's gonna do a meniscal surgery, and she came and talked to me, she knew I was there for her, and I said, I'm not allowed to talk to you, and she's like, well, can you just get the surgery through, because I'm gonna be 100% pain-free after this surgery. And I went, who told you that? Because that's not true. So you are shortchanging your client, and if you don't care about that, then I can't care about that. I will still do my best on the back end to do the right thing, but it's not personal. I don't care. You don't not have me.
Good question.
Well, and for some reason too, I've noticed a lot of the injured workers think the nurse case manager is their enemy. They don't want them in the room. They don't want to speak to them. They feel like they're there against them. And
There are
I
those,
try to educate them and let them know like they're here to help you out.
and that
not
helps
against you
tremendously,
and-
it does. There are times, rare instances where you have that problem claimant, and I have one, and the attorney came on and he was like, please don't be offended, and I'm like, oh no, you're a blessing. You an absolute blessing to be there. So, you know, I don't usually have an issue, but I right up front talk to the attorney. We're a resource for the attorney for that injured worker, but I will go to along with whatever expectations.
Yep.
So the next slide is like injury criteria. This is just a little bit of an idea of when to bring in a case manager. So if you have somebody hospitalized, or if they're admitted with, under observation for less than 24 hours. And of course, there are some referral sources that want an immediate response. And like Cody said, it may not be need case management, and we'll let you know that. Not always is everything diagnostic or diagnosis based. It's sometimes the adjuster or the employers want a case manager to go to the hospital. They want them to be able to offer support, get the medical records. So what do we do? My cases are 99% of the time they're in the hospital. I contact that hospital case manager. I find out the protocols so I can make an on-site visit. Sometimes if they're, depending on the circumstances of an injury, that injured worker may be under an alias, and that takes a different kind of security clearance to go. I also try to reach out to the injured worker and the family to let them know a little bit about case management, introduce myself, give them my contact information, let them know I'm going to come down. When I do go there, I get a release signed so that we are able to get records. I call the adjuster so that we can get on the same page. She knows exactly what's going on, he or she, with that claim or injury, and find out their contact and preference. I very rarely, in the cases that I have, usually the referral source doesn't want me to talk to the employer, and sometimes it causes a problem. The employer wants more information than I can really release, some confidential information. So it's basically on a referral basis. And of course, I contact the injured worker's attorney and anybody else listed on the referral. I get permission from that injured worker, that attorney, so I can know whether I can see the patient, talk to the patient, go in the exam room. Sometimes I have them where I can't go in the exam room, but I can still have contact. So I just try to get everybody's expectations. If by a miracle chance there are medical records to review before I do that on site, that is so beneficial. Then I get that appointment scheduled. I also start the discharge process with that hospital case manager immediately. So many times I have gotten a call at 4:30 in the afternoon,
On
and we're going to discharge this patient, and here's your list of DME, and I'm scrambling to get the order, to get a DME company that is even open at 4:30 on Friday, and to get that stuff to that patient that weekend. We also talk about whether they're going to go home or are they going to go to rehab. So a lot of my injuries are spinal cord injuries and TBIs. And the company I work for, we focus on trying to get them transferred to a center of excellence. So that's like Denver, or Craig Hospital in Denver, Ter Memorial in Houston, Shepherd in Atlanta, or I think there's one in Chicago. There's a couple of them. And they focus only on that rehab, on that body part, the brain injury or spinal cord injury. It could be for 4 weeks or several months. They bring the family in because that family member needs to learn how to care for them. So I focus on trying to be able to give them that best outcome, and those centers of excellence have earned that award, and they do provide the best outcome. And I've had patients though that have gone there and not behaved, and been kicked out.
We can get your C4, we can get those records quickly, we make our connection with the case manager, we can get your, cause you need information quickly. You need to know, what am I accepting, what am I gonna be paying for, you need to start projecting your file, you need information.
focuses on the most
for a brain injury and you go, I need an evaluation by Psych or for a speech therapist. Well, why? They're fine. You have a
How do you
hemorrhage.
know? Right.
I need to know what my baseline is. I need to know what we're gonna be testing later, and they'll fight us.
Yeah, they have.
Look, get us what we need so we can clarify where we're gonna need to go in the future.
So also, one of the most important things I think case management does is help that family and that injured worker understand why we're there, our role as their advocate, give them the contact information, let them know how often we're gonna come. We keep them informed of what to expect next. They're so overwhelmed. People are coming in and out of that room, they're calling, they've watched Talk to Family and Friends, they've looked on Dr. Google. So we need to be the ones that educate them, kind of hold their hands, build that trusting relationship, and help them get through some of this. You know, again, we meet with the case manager, the bedside nurse, so we get constant updates. And if I don't go one day on site, then I can at least have that relationship and call and get the updates. We need to find out who's treating this person, who admitted them, who did the surgery, who's overseeing them at the hospital, and who is going to follow them afterwards. With the cases that I have, the company I work for, each case has a medical team on it. And it could be multiple doctors, nurses, PT, you have a prosthetist if there's amputation, and they also work with the treating physician so that everybody's on the same page. And again, I start that discharge planning right away. Next slide. So how can we reduce your costs? So sometimes you just need an outside source to help you make sure that that injured worker is getting the proper care. And this level of care also ensures that they get the right treatment, and you guys don't have to pay for extraneous medical care. We also can identify a lot of non-industrial conditions or treatments that will affect the healing and outcomes that affect your costs. We work to try to avoid any unnecessary treatments, procedures, surgeries, PT. Those are very, very costly. We coordinate medical services to maximize the treatments, and we try to get the releases either full duty or detailed one with restrictions, which helps reduce your indemnity costs. And lowering case management fees by ensuring, like Cody had mentioned, ensuring the correct level of case management is assigned for a specific claim. Sometimes they'll ask for an urgent visit and at the hospital, and that's a CAT response, but once I do my report and my assessment, I'm like, this isn't a CAT claim, it needs to go to field case management, and that will save money. Go to the next. So here are some of the benefits, other than, you know, we're just awesome. So we are the center point of contact and coordinating all of the care with the varied healthcare providers and facilities. We develop that trusting relationship with that injured worker and their family. We don't just treat that injury. We have to treat that whole person, their emotional and their physical. I always tell the doctor, and that's where doctors are sometimes, no offense, are sometimes just focused on whatever it is, at whatever body part. And I'm like, no, we have to treat the whole mind, body, and soul to get that whole person back to the best they can be. We need to understand the severity of their injuries and how it affects their mental outlook on their family relationships. This has jacked their whole life up in a matter of seconds. And they look at themselves differently. They don't have the same relationship with their partner or their kids. They worry about their finances. And that's one of the first things that everybody asks me is, when am I going to get paid? And no, and we try to help them with a little bit of that.
I mean, setting the expectation.
Yeah.
They have to set up their claim. They have 30 days to determine if they're gonna appropriate. We can't do anything till we have the C4. They can't even start the clock. They have to accept it. Then they have to get wages from your employer. And then once they get that, they calculate your then you'll get paid back to that date of injury. But it takes 3 or 4 weeks. I need you to know that and hear that. so that their family can plan for what they have to do.
And at that time,
It's
there's-
setting expectations so they're not angry right off the bat.
And sometimes you have to repeat that because they're so overwhelmed and they're so scared. I also have to monitor, we have to monitor their emotional status. Sometimes these injuries are so severe that they know they're not going to be able to go back to the lifestyle that they had before, and depression sets in. And a lot of them will deny it or try to hide it, and then they have the thoughts of harming themselves, so we get the psych in right away. We have effective communication among the injured workers, the families, the insurer, the providers. We care coordinate with all the transitions of care. We assist that injured worker in making decisions regarding their treatment, and educate and reassure and make sure they understand so they can make an informed decision. Because again, they have a lot of outside influences coming in, and Dr. Google comes up quite a bit, and they think that they need this kind of treatment, or so-and-so had it, and they're 100%, so I need it. Or you have the patient that has had so many surgeries, hoping that one more will take care of all his pain and he'll be 100%. And you have to sit down and go, there isn't a magic wand. There are no more surgical options. And then the repercussions that come from all of that. So we do a lot of hand-holding with not only that injured worker, but their family members too. We're able to get your reports a little bit quicker, updates, participate in coordinating and improving the injured workers' health and their well-being. We provide a lot of health promotion and disease prevention along with case management. So I nag them about, their blood sugars. Are you taking your medication? Are you doing this? Because it will affect the outcome and the healing of their injury.
And ultimately, I always say to my patients, I'm sure in some form you do, ultimately, at the end of this, everyone is going to get paid who's involved. Your physician's going to get paid for their surgery. Your TPA is going to get paid for the job that they do to administer your benefits. Your employer, the attorney's going to get paid. Everyone's going to get paid. No one lives your life but you. So in the end, what effort you put in to make yourself better only affects your life, because everyone else is going to walk away having done their job and be fine. You have to live with you. So if you aren't willing to do it because somebody told you you're going to get $5,000 extra, if you drag it out 6 months and you keep going to PT, but you're not doing the effort and you're not doing the exercises, we're going to see it, one. And two, you're not helping yourself because you're going to make yourself disabled when you don't have to be.
There's a lot of it is working on their mindset.
Yeah.
At
the end, you live with you.
So I talk a lot about medication education and treatment compliance. Medication education is really one of my big sticklers because narcotics we have them, they're beneficial, you need them to heal, but then I immediately start talking to them about alternative methods. I have some patients that have been on chronic opioids, and detox and rehab is a tough road to go down for everybody, and not always very successful. But there are things where I've given them a pain journal, and I'm asking them, okay, when you took it at 9 o'clock, and now it is 1 o'clock, and it's not just the little happy face of 0 to 10 pain scale. It is, here's an explanation of what it looks like. And if you're saying your pain is 10, your butt better be at the ER, because that's pretty freaking severe, and there's something else going on. But maybe it's a 3 or a 4 or 5. Can you do something different and postpone taking that pain pill for another hour or 30 minutes? Or can you take Tylenol or ibuprofen to stretch out the time so that you begin to take it every 6 hours and then a little bit longer? It's a process. It's something I start early because the outcomes, if you don't, are detrimental. We have we monitor overuse and reducing healthcare costs. We also are always their advocate, that patient's advocate, within the healthcare system to provide the best outcome for that injured worker. My last slide is our goal is to help as many people as possible.
to an impairment rating. It really is to just be available.
would normally do for the patient who's injured, the injured worker themselves. You provide that extra, whatever you wanna call it, sauce.
It's education.
Yeah, you
90% of the time, it's education and support.
Absolutely, and you help the families because that does make a difference. And I see the difference when somebody is by themselves and they don't have anybody.
Well, if they're by themselves, they don't have anybody to, how do they know what DME they need? Or
Right.
how do they get their home modified? So that's where we are that navigator. And we advocate, this is what you need.
Family member in from out of state or where else, or close friend from work that is willing to help them out. Those are things we may not, as an employer, may not consider at that point in time because we don't know.
Yeah.
You know, so we do ask that question and ask our nurse case manager, hey, do they have any family here? And if not, where's
And
the closest
that's one of
one?
our first questions in our initial interview is not only who do you have at home, what does your home look like? Do you
Yeah,
have
it's a
stairs to go in
two-story.
or out? What kind of shower do you have? Do you have to drive yourself? Do you even have a car? You know, like we're asking all those questions so that we're prepared to make sure they're supported once they're out.
Yeah.
My only comment is when they get to MMI, you close the nurse.
Yeah,
So-
usually we're off.
Yeah.
That's it.
Yeah,
So I wanna just,
it's your turn.
Go.
but I'm not ready to talk about legal stuff.
Okay, wait, but
So,
let me.
interestingly enough, I do want to share a war story regarding nurse case managers, and strangely, I got a call during this presentation from an adjuster who was involved in a situation that I want to share, which I'm not sure if that person thought I was going to answer the phone during the presentation. However, I believe that it wasn't a coincidence. And so, while these lovely ladies have shared with you what their role is in being a patient advocate, again, I don't know that that's understood generally by the claimant's bar. Particularly the case that I have was in Northern Nevada. The nurse case manager got involved with the file, found some problems with the diagnosis, and through a series of communications with the adjuster and the doctor, tried to get that clarified. The attorney took great umbrage to this and used those communications to paint a picture that the nurse case manager was simply in the file to shut down the claim and hurt the claimant and steer the doctor, right? So this is Northern Nevada. The judge bought into this argument, resulted in one of the first time in my 22 years of having a adjuster subpoenaed to testify at the hearing regarding this communication, and so it was pretty absurd. So again, I think it's important for us to make sure that
That
are
one
we
is.
going through these? Yeah. So it's important in that communication. You want to be sure of what you're documenting, how you're documenting it, and making sure that if you're asking the doctor for, hey, a clarifying opinion, that your communication is very clear that that's what you're asking for, so that somebody doesn't try to style you as some nefarious actor who's trying to make the doctor change their opinion about something. Because in that case, the doctor did rightly revise their position because, as you've said, no offense to doctors, they have a different job to do that's not patient-facing like yours, right? And so there may be information that the doctor missed, and asking for that clarification should not be interpreted as, oh, they're out to get my guy, but it unfortunately is. Doctor, you had a...
Yeah, just from a physician standpoint, so this is what I did. I worked in the rehab units for years, and
little louder, Doc.
I worked in rehab facilities for years in residency, so this is kind of what I did. So the biggest thing is what you're saying is exactly right. Physicians are overwhelmed with a lot of things that we're all overwhelmed, and so they do get hyper-focused on things. And so, not that they miss things necessarily, but more like need things brought to light. But I'm more commenting, no questions, just how needed you guys are, because I don't think it's more of like, hey, it's beneficial to have you in a rehab facility. I think you guys need it, and you guys have to be there. And PM&R, we kind of pride ourselves in being interdisciplinary approach. And so case managers, nurses, all of the above, therapists, we're all working as a team, and you guys are all bringing in parts to the team. And so they're so needed in that field. I saw it for years, and if they're not there, a lot of times the family members don't know what's going on, and they're like, I don't know.
And they're overwhelmed with information,
Yeah,
especially in
you
a
guys
spinal
do
cord
know.
or brain injury. They're overwhelmed. They don't know how to handle any of it.
And it's a team approach, and usually we're just working together. Hey,
It is.
and you guys are like, oh, DME is like, oh yeah, they probably need this, and we're helping out. So, not a lot of times we will forget a few things here and there, and that's where like
That's where we come in with like, I need this, and this.
Right. And the
Yeah.
physicians, for their part, we get on the physicians a lot, but remember, I always say, like, the physician can only deal with what's in front of them.
Right.
They are seeing that patient literally sometimes for 5 minutes. And if that patient walked into the building and they're doing great, and you have surveillance video of them doing whatever, or you have, I don't even know, the employer saying, hey, they're here every day, they look fine, right? Whatever you have on your side. That doctor may only see them coming in with a walker and complaining that they can't, and moaning and wincing, right? It's not that the doctor is just trying to drag it out for fun to get more money. They're only seeing what they see.
And they only can take
And
that
they can
history.
only take it they have to take their patients at their word.
Yeah.
Until the patient shows themselves to be untrustworthy, they have to trust their patient's word. So it's not always as nefarious as everybody wants to make it. Well, that doctor always drags them out forever. No, maybe it's just because that's what they're seeing. They're doing their very best to treat what they're seeing in front of them.
Glenda Lee Jackson, nurse case managers are crucial to proper case management in complex and CAT cases. Nicole Marley, nurse case manager, nurse case manager, nurse case manager, CAT claims. CAT claims need nurse case management. Okay, let's go.
That's all you, sir.
Awesome. All right. Well, here we go. So my first slide here, we're going to talk about some key legal terminology. You'll tagline there, you ought to know, I don't have the rights to any Alanis Morissette music, and it's not in my range, so I'm not going to sing it. I'm not going to sing it, but you get the idea. All right, so let's see, is this going to work? Yeah, our purpose here is to, so look, kind of the genesis for this this particular program today, I don't mind taking credit for it, because we were having as a board a discussion about what we needed to do for our next presentation, and we were talking about, we had something that was supposed to go today that we had to move to another time, and we needed to fill something in, and we were just discussing the idea that terminology is so important, and unfortunately we live in a world where people don't actually apply themselves to the things that they're doing. You've got so many reports that come past your desk, and I was taught something by my father when I was a kid, and that is, if you're reading something and you don't know what the word is, the answer is not to skip it. The answer is to go and figure out the meaning of that word, because you've learned nothing and you're not prepared if you're just reading past. So it took me a while to figure this out. But what I would do, I'm reading something and I would go, hey Dad, what's this word mean? My dad would say, that are very important. Crapping on the DA's office because or AG's office because they never prosecute fraud, and there's some reasons why they have to be a little bit more careful than maybe we do. All right, so preponderance of the evidence. This is standard in civil cases, obviously workers' comp, and what a preponderance of the evidence actually is simply more than even. The trier of fact, whether it's a judge for workers' comp, it's going to be administrative law judge, it's going to be your hearings officer, has to find that the weight of the evidence is greater for one side than the other. What you want to do is focus on the weight and the quality of evidence than numerical percentages. And to illustrate that point, a preponderance this is a definition from a legal source, that the preponderance of the evidence standard is evidence that must tip the scales in favor of one side by a slight majority. And so you see, I've used this language before, it's literally the tiniest bit past even. It is not, as unfortunately where I get into my rant, you have people who will say that it's 51%. It is not 51%. It is, you can use any mathematical notation that you like, but it is 50.0 to infinity nearly, and a 1. Right? So these are several different mathematical expressions. I don't understand the one at the bottom, but it's something about limits. People who know math can maybe explain it to you later. I don't know. I went to law school, so I didn't have to do math. But I do know the difference between 51% and more than 50. And so to beat this dead horse a little bit more, let's see if I can get this to slide over. There we go. Okay? And I think we can move on. Not 50. 1, not 51. And so the reason that you need to understand this for my adjusters in the room is this. You need to understand where you are in a case. I will tell everyone who will listen to me, new clients who come on board, old clients who get frustrated, I am not a sunshine and rainbows type person. I am not going to tell you what you want to hear. You're losing if the claimant has slightly more than even evidence. And you need to know that you're losing so you can stop that from happening. I tell my associates and everybody who works on my team all the time, our job is not to figure out how we win and stop thinking. It is to figure out how we lose and stop it from happening. Figure out how you're going to lose, which means you need to know where the bodies are buried, and then stop that from happening. So, in a case where you have a doctor who has checked the yes spots on the C4, irrespective of your feelings about whether this is a legitimate claim or not, you need to understand that without other evidence, you're losing. You're going to lose. It is not a heavy weight to have that doctor checking the box, although it's been outsized. That yes box means way more than it's supposed to be. No offense to my doctors in the room. The ultimate question of whether a claim is compensable or not has nothing to do with your opinion as a doctor that you think the claim is compensable. What the C4 should be asking you is, based on the information that you've seen, coupled with your examination of the payment of the patient, does the description of injury provided match the mechanism of injury and your diagnosis. Instead, the form asks whether you think it's job incurred. And I don't care, number one, job incurred is not something that's defined in our act. It's not even a term that's used. Why it's on the C4, I have no idea. Did attempt a couple of times to get the DIR to revise that. Came real close a few months ago. Then they decided they didn't want to do it. So, in any case, this might get legislatively updated, but at the end of the day, it is the administrative law judge, the appeals officer, or the hearings officer that is going to make a legal determination as to whether the claim arises out of the employment. The thing that we need to understand from a defense standpoint is, even though an opinion on a C4 that isn't based on substantial evidence is not the strongest evidence in the world, that isn't the requirement. It's just more than what you got, right? You got nothing, and the doctor says yes, then you're swimming upstream, and you need to understand that. Okay. The next standard of proof that is relevant for workers' comp is clear and convincing evidence. Clear and convincing evidence comes up in places like claims for 180 for psychological claims, and this is a standard that is between the two. So this is a little bit higher than even, and this one I'm a little bit more comfortable giving you some numbers. The evidence has to be something that is highly substantial. It's a higher standard, somewhere between 70 and 80% of weight. It's, again, more rigorous than preponderance of the evidence, and the evidence needs to be clear and direct. Here I went into maybe using some boxing metaphors. A clear and convincing standard is something like a TKO, right? It's not a complete win, but you have convinced at least enough of the judges that are looking at this that you have proven what you need to prove. So when we're looking at whether somebody has a claim that's compensable under 180, and we're not talking about a catastrophic event, but simply something that arises out of a time of danger, we're going to have a appropriate medical professor look at that, a professional look at that, and they're going to have to be able to demonstrate clear and convincing evidence that that claim should be compensable because the claimant is having mental distress, whether that's PTSD or what have you, right? And then we come to the AG's office and their burden, which is a slide that doesn't match up with what I'm saying. So, but good thing is I happen to understand. So beyond a reasonable doubt is the standard that we're going to use in criminal proceedings. It means that there is no reasonable way for the trier of fact, again, whether that be a judge or jury, to interpret the facts in any other way than this is something that happened, right? And so, turning back to my boxing analogy, if the click will work, instead of a TKO, we're talking about a knockout. There's no question. You are literally on the mat. We saw you get punched into oblivion, and it's not a decision that we need to spend a whole bunch of time thinking. And that's what a beyond a reasonable the line. I think everyone needs to understand because they do come up. And without reading those to you, we'll just jump right into jurisdiction. So jurisdiction isn't something that comes up in workers' compensation often because it's typically pretty rote. You have an employer, you have an employee, you have an injury, and we're going to have a C4 that starts a claim off, C1 and a C4 that get a claim going. But sometimes the issue of jurisdiction comes up. I'll be very professorial and do some Socratic method. What are some examples of when jurisdiction comes up in your cases that you've seen?
Coming and going rule?
Coming and going rule is more of a causation question.
Okay.
But yes.
If they're truck drivers, if they're bus drivers, if there's someone that leaves this jurisdiction, I mean, if they're here and they get hurt here, then that's this jurisdiction no matter what. If they are from here, they work here, they're employed out of here, but they're working in Utah, or they're working in California, or they're working somewhere else, then that might be where your jurisdiction.
These certainly present sometimes. Anne, are you creeping up on me? It looks like you might be. I feel like you're creeping.
She hit it perfectly. I think jurisdictionally, that's where we have the problem is when it comes to someone getting hurt, not hired here, doesn't live here, doesn't all that. So, basically, is there coverage here?
There is that type of jurisdiction, but there's another one that is probably more common that you probably don't think of being a jurisdiction question, and that is when you have the statute of limitations run. So if somebody doesn't file an appeal of a HO determination within the 30 days, or if the claimant doesn't appeal your determination within 70 days plus 3 for mailing, until such time as we have electronic filing, at which point that'll go away.
Theoretically.
Theoretically, yes. Yeah, I guess the division had some setbacks with their regulations that they were trying to publish last week, so that might be delayed a little bit. But yeah, so those are other examples of jurisdictional problems. And so to understand this, I didn't take Latin in school, but I guess sometimes I wish I had. It seemed really boring. Good. So if you understand the Latin, you really have a good sense of what these terms mean. Jurisdiction means can the court speak? Juris, court, diction, speak. Can the court speak on this issue? And there's several reasons why the court might not be able to speak. The first, and this is more traditional kind of understanding, but you'll have the slide so you can refer to it if you'd like. Subject matter jurisdiction. Can the court speak on this subject? So for workers' comp, they're not going to be able to speak on personnel issues or torts. Their jurisdiction is limited to the Nevada Industrial Insurance Act. So the HO and the AO can only talk about those things. Same thing that the district court can't hear our cases unless it's on a petition for judicial review because they only have jurisdiction over that subject matter. Personal jurisdiction is whether the people that are involved are subject to the jurisdiction of the court. So an example that you gave of somebody who works out of state and their employer is out of state, it may not be appropriate to file a claim in Nevada because there may not be enough connection to the people to a claim in Nevada. And this comes up in things that I deal with various sports teams that we represent in the firm and whether or not a claim is properly filed here. Or I think somebody gave the example, I think, of whether you have somebody who is a long-range truck driver that doesn't work for a company that really has any connections to Nevada except for maybe the accident happened in our state. So there are a number of different ways where that can come up. It's not extremely common in workers' comp, although I've got a pretty complicated one in inventory right now that we're fighting over. And so these can get very interesting. What also comes up with those is choice of law. Is the claimant going to be trying to file a claim under the Nevada Workers' Compensation Act because they're going to get more benefits than they would in another state? So these can be complicated, and quite frankly, this is something that at the hearings office level, a reminder, our hearings officers are not lawyers. They are not ALJs, administrative law judges. They don't even have any special legal training. And so some of these issues are more complex than they can actually understand. In fact, the case that I just mentioned that we have in inventory, I won, but the decision from the hearings officer is quite frankly preposterous because they don't understand this concept of jurisdiction, right? It's not something that is easily understood by lay people without putting a little bit of time and effort into it. So, what you need to know as an adjuster about jurisdiction is if you have one of these situations where you have a reason to suspect that either because of subject matter, because of statute of limitations, or some other factor that the court shouldn't be ruling on it because they don't have the ability to speak, then you want to make sure that you understand that, talk about it with your attorney so that they can get addressed. So, for example, an untimely appeal of your determination on the 80th day, there is no point at which, if that is a true fact, that's correct, that the hearings officer should be issuing any kind of determination other than a dismissal, because they are not allowed to speak on the matter. You don't care what you think about the facts, you can't speak. Your only job is to say, this is dismissed, it's not properly performing.
I see California sometimes taking claims. Can you comment on that? I mean, you know, we've already gone through the what we consider the outline. I can't think of the acronym for it. But then they go to California and they file, and California goes, "Yep, we'll take it."
So yeah, I mean, we don't have any control over. I guess the interesting part is for those of you who work for insurance companies, TPAs, it still may affect your company, right? Because it's going to be somewhere else. In fact, the case that I've mentioned a couple of times, there's a question of whether the employer / insurer or TPA wants this claim to be in Nevada versus it ending up somewhere else that might be a worse jurisdiction for the company, right? And so those considerations come into effect. The bottom line is, if there are sufficient contacts with the forum simply means the state, so if there's sufficient contracts with the state of Nevada and there's a policy, you can have a claim filed in Nevada. There may be more than one proper jurisdiction, but there should only be one, right? We shouldn't have two claims, one in California and one in Nevada for the same set of circumstances.
And if they're in California and move to Nevada, it doesn't change to Nevada jurisdiction.
Correct.
It's still a California claim,
That's right.
et cetera, and that's the other place that I've seen it.
And some of the other things that come up, going back to kind of the statute of limitations on filing a claim, that's going to vary between the states. And someone may file a claim in California and have that claim rejected for whatever reason, because maybe it should have been filed in Nevada. If the statute of limitations for getting the treatment done or filing the C4 or appealing a determination has lapsed, what is the impact on that in the claim? These are can be complicated questions that depend on the facts, but saw a question, was it Dolores?
Yeah, well, with claimants filing are being treated in California and have their accident in California, a lot of doctors don't want to see them because of the rates. Just saying.
Well, I think that's true, and I think that that's also part of it. I mean, what the claim is gonna cost is both the doctors look at it as well as the employers. And that's why sometimes the employer goes, "Oh, I'd rather have it in California."
issue with a determination from the appeals office, the only hearings office and how he himself was shocked that his folk, again, who are not attorneys, did not understand this concept, and they're the people who are required to issue determinations regarding it. And so let's talk about res judicata and what it is, and then we'll talk about what he was seeing. So res judicata, res is a thing. Res is the subject. Judicata is judged. So a thing, the thing has already been judged. And that's what res judicata is. The concept of res judicata is to prevent clogging up courts with things that have already been decided. And so what the requirements are for this to be the case is that you have a final judgment by some court or a tribunal. It's the same parties. So you have to have the same folks on both sides of the V. The claimant was there, claimant's counsel was there. If counsel changes between the claimant, that's not necessarily going to preclude res judicata. It doesn't mean that they get to keep moving around with attorneys and have a different shot at it. But you have to have the same parties involved. So, for example, if we have a case of, bless you, you have a case where we have a question as to whether something is lasting juris exposure, and you have my client is the employer and the claimant is on that side, and for some reason the insurer is not involved. Well, that's not going to be res judicata if we have somebody presenting that against the insurer. They weren't there. It's not the same total number of parties. So I underlined there, you may or may not be able to see it because we're not using the full screen, but either the same parties or they have to be in privity. So privity is simply a term that means that they are aligned with the same interests. So an agent who's able to bind one of the parties would be in privity with them. And the same cause of action. It has to be the same thing. If it was a claim about scope that was previously decided, and we're now doing a claim about whether somebody's entitled to TTD, it's not going to be res judicata. It's not the same thing. So it has to be the same issue, the same parties, and you have to have a final order, final judgment. So what Mr. Hardy said that he had seen was several decisions where some folks that work for him had written this as RAY apostrophe S judicata. There's no Ray involved. It's not Ray Charles. It's not his judicata. It's res judicata. Okay. The subject Ray. All right. I should say questions. Just blurt them out anytime. No need to wait till the end. So, another concept in this that comes up that you need to understand, and lately seems to have been more struggle than I think it should, is whether a question is moot or not. And so, moot simply means that the issue is no longer relevant, or it has been resolved, or for some other reason we don't need to waste the court's time with this. For example, we have an appeal or determination regarding whether the claimant, since we know, and again, I don't want to bash people that aren't here. Kevin could have been here to defend his side, but he's not, so we'll take advantage of that.
We do have plaintiffs.
We have someone who has appealed every determination that you've issued, right? One of those is scheduling of the PPD. And meanwhile, the arrow of time has moved forward. The claimant has had the PPD evaluation. the issue of whether the claimant is going to go to the appointment based on the letter you sent is now moot. The evaluation has happened, right? So it has become irrelevant or has resolved otherwise, such as we have litigation on scope of claim or some other issue that has been resolved because the claimant has, in the meantime, accepted a PPD, right? So that's what mootness is about. We have had more litigation than I would expect on the issue of mootness, trying to get things dismissed. If an issue is moot, or if there has been a determination already on this, such as the prior term, res judicata applies, what we should be doing, it's hard to do at the hearings office level because it's not really set up for us to have motion practice, because a motion to dismiss would require the claimant to have X amount of time to respond. You've got responsive pleadings, and meanwhile, I got the notice of hearing or the referral from my client a day before the hearing or 2 days before the hearing. There isn't enough time to have that work out. But I can make those and do make those motions orally. I just saw a pop-up on the screen here from my friend Mike Barkley. The term is moot. Listen to my enunciation. Moot, not mute. Mute is what you want to do to me right now so that you can get out of here. Moot means that it's not right. Exactly. So thank you, Mike. I appreciate that. All right, moving on. This is one that I want people to understand more than they do. We use the term, something has gone wrong with my slides here. This is, again, not the right slide. Arbitrary and capricious. Now I have one for arbitrary and one for capricious, but this should basically say these terms are used in conjunction with one another frequently. And the reason that they come up in this context is, let's talk about where you're going to use this. It's going to be in a motion for stay, typically, or an appeal from a hearings officer. It can happen when we're appealing to the district court from an appeals officer. And one of the bases for appealing that determination is that we got a crap decision from the trier of fact, whether it's a hearings officer or appeals officer. And one of the ways that we describe that as lawyers is we don't say that the decision was crap. We say that the decision was the product of arbitrariness or capriciousness. And so these terms are similar. They are used in conjunction often, but they're not exactly the same. Arbitrary, I think that in the normal language we all kind of have some sense of what that means. It's like, you just did this on no basis. You're just doing stuff because you want to do it, right? And so, again, this is not the... What the heck is happening? Thank you. I thought I had. Okay.
There you go.
So, there's the Latin for you. It's arbitrarius. It's based on personal judgment. It is something that is based on a whim, personal preference, no objective criteria. It's not well reasoned. It's not following the rules. I'm not going to ask for a show of hands because I'm sure you've all seen some decisions that might have, at least in your opinion, seemed arbitrary from that standpoint, right? So it's heavily influenced by a personal opinion or bias of the decision maker. No consistency, can't figure out where this came from. That's arbitrary. The distinction between capricious, if you think of capricious, the word, it kind of comes from the idea of caprice, right? You're just lackadaisical about it. You're not giving it the seriousness that it deserves. You're treating as if it doesn't matter. And so the key points here, it's impulsive. There isn't law based in deciding that. There's in deciding what do the facts because we don't want the claimant's unrebutted testimony. The claimant's unrebutted testimony wins one day away with my pickaxe and I get no breaks and they will give me no water. The claimant's unrebutted testimony was that he wins. Period. That's what's going to happen 100% of the time if you're not producing witnesses to address that. If you have produced a witness, guess what? The hearings officer gets to decide who they believe, irrespective of your best efforts, and that isn't generally going to be the kind of determination that can be reversed on a motion for stay because you don't agree with what they came up with. Now, if they've got the law wrong, then there's less to stop the reviewer to reverse that, right? This also comes, I should have had this terminology in here, and I did. I apologize for not having de novo. But let's talk about de novo in the same context. De novo is Latin, it means of, it's new. So when we have an appeal from the hearings office to the appeals office, and they say that that's a de novo appeal, I'm getting your signal there, Doc, a little bit louder. When there's a de novo appeal, what it means is the appeals officer is not bound by what the hearings officer has said. Again, our appeals officers are lawyers. They are what most jurisdictions would call an administrative law judge, or an ALJ is the language that's used. Their I know that we live in a society where we've kind of forgotten this, and I'm sorry to be the one to break it to you. Not all opinions are created equal. Right? Somebody with the years of training of going through law school and becoming an attorney and then becoming an administrative law judge is going to be given a little bit more credence still in the courts, we'll see if that holds, than somebody who doesn't have those credentials and training. And so, based on the way we've structured it, they get to decide without having to be bound by what the hearings officer has said in either case. Going from the appeals office to the district court, the district court, by statute and design, because now we've got two former lawyers who are now judges, disagreeing potentially on how these facts should be viewed, the district court is bound generally by the determinations of fact made by the appeals officer. They have to give that deference unless it's the product of arbitrariness or caprice. So that's where we get to arbitrary and capricious. Okay? Questions?
We got about 2 minutes.
Holy moly.
I know.
And as adjusters, don't be arbitrary and caprice, because that's where I see it.
That's true. We can be arbitrary and capricious as well.
I see it with the adjusters.
Again, it's
an
based on
emotional
personal
decision.
bias.
It's emotional
Right?
decision.
It's based on, I didn't like the way that went. I don't believe
I don't
that. My
believe 'em.
gut tells me that.
I don't believe
All right, you gotta, as an adjuster, you gotta follow the facts.
Yep.
All right, so I'm throwing in a bonus here. I think Glenda Lee is on somewhere on the out there in the
she
ether.
Is. She is.
She asked me if I would please include a discussion that I got a hard. Thank you. Can you talk about prejudice? Because I see a lot of questions or confusion in my folks about this. So we're not talking about bias against people in the world or what have you. What we're talking about is whether a claim, a motion, something that one or the other of attorneys has done is being dismissed by the court with prejudice or without prejudice. And it's not that complicated. With prejudice, the Latin for prejudice means harm or injury. So with prejudice means you're done. You have You have filed an appeal of this determination regarding transfer of care, and I am telling you that it's a no. It's a no from me, dog, and I meant it. Not only is it a no from me, it is a no from the entire
You're
court
till
system.
forever.
Go away. Talk to the hand. See you later. All right. Without prejudice is, I'm not really feeling it right now, what you're saying, but I'll let you ask me again later. You can ask me again later. Right now it's a no. Maybe if you say it again in the right ways and the circumstances have changed, I'll let you ask me this again. Right? So that's the difference. With prejudice means, you just think of it, extreme prejudice, you're done, executed, dead. Without, we'll see. Okay?
If you show more proof, if
You show more proof, if circumstances have changed. You're asking Mr. Hooks for me to grant a stay on this, and rarely would I get a denial of a motion for stay with prejudice, although I do have one example. The appeals officer isn't there anymore, and it wasn't to me, it was to counsel prior to me on a case that was a PTSD case. Claimant had been robbed at gunpoint in the bank that she worked at, and had this ongoing PTSD claim for something like 25 years. And I was brought in, Dalton, can you help us get this thing shut down? What had happened at some point is that they had moved, they wanted to have an IME, and the judge said, not only no, but stop asking me, because you asking and sending this woman to IMEs is causing her PTSD to get worse. The fact was that this person was going to her psychologist, who she had developed a relationship with.
Like a romantic relationship?
Correct.
Willis kind.
Oh, that's like a Jerry
And
Springer show.
yeah, it was very Jerry Springer. And there was pecuniary interest here to keep her in therapy, but the therapy was not about the alleged incident from 25 years ago. It was about my brother is awful, my family stinks, right? So it took a while to get over that, but they were sitting on an order with prejudice that they weren't allowed to move the case forward.
So just real quick, we are at time, it's noon. If you guys online have to get off, you can get off. You guys have spent your 3 hours, you will get all your credits. But if you wanna continue, Dalton, and do you wanna, I don't know.
I'm gonna just jump over because there's a lot there, and we are past time. So what I will do is, if anybody has a term that they want for me to define or try to
Discuss or
define,
talk about.
I'm happy to do that, and then we'll wrap this thing up. So questions? Anybody get this reference?
Yes.
Okay. If you don't get the reference, ask somebody who does.
Dr. Kia?
Can you define substantial?
No. Next question.
And that's with prejudice.
And that's with prejudice, that's it.
Can you be more specific, Doc?
All right.
Give me some.
616C175, substantial contributing cause. Can you give me some idea what substantial should mean in that?
Yeah, I mean, you can look at substantial kind of like clear and convincing, right? It is a higher standard than, a little bit. Substantial means it's weighty enough in that context to have almost caused this condition on its own. It is the primary factor. We didn't get a chance to talk about
The
Is it you?
first gift is from Hand Center of Nevada is a $25 designer DSW gift card from Hand Center of Nevada.
See how good that
Winner
was?
is Dr. Probert.
Try shoes for your kids.
All right, the
Oh.
next gift is a $25 TJ Maxx from
Don't skip that
Dr.
one yet.
Maxwell Vest, Hand Center of Nevada. Winning person is Roberta Anderson online.
Where'd you get that one? Is that the one
That's
that?
the one you called
that's
first.
one.
Okay, yeah, you're gonna put that over here then.
Next one is a $50 Amazon gift card from Corvell.
678-675.
Wow.
Yeah. How convenient.
Nice.
I know.
Exactly.
Next
Just
one
gonna keep it up.
is a $50 TJ Maxx gift card from Dr. Andre Razadin.
678-613.
Close.
Yeah.
Next one is a $25 Amazon gift card from Trish Gibson. No.
Six,
Colby
seven-
Young.
Dr. Young.
I don't know.
678-645.
645.
Oh,
Alright.
yeah.
Vince Doyle.
Next one is a $50 Marshall's gift card from Dr. Manning.
678-659. I got a check. Don't look.
Don't look.
667. No, I'm sad. We're gonna put these over here for a minute.
What was the number?
No one?
What was the number? Do it again.
659 or 659. 678-659.
Going once, twice. What is it?
659.
Pick a yellow one.
Pick a yellow.
Look at that.
Winning person is Amber Nelson online.
Amber, we love it.
Give it back to Trish.
She's going to dinner with
All
us
right,
Thursday.
next gift card is a $25 Cinemark movie tickets from Nevada Orthopedic and Spine.
632.
632.
Woohoo!
Wow,
Yay!
rigged.
Rick.
All right, the next one is a $25 Ulta Beauty gift card from Hand Center of Nevada.
600.
600.
Oh, me.
Woohoo! Yellow.
Yes, ma'am. Next one is a $50 Bath and Body Works from Capital Vogue Consulting. Winning person, Frank Ramirez, online. Next is a $50 Amazon gift card from Dr. Amit Parekh. Winning person, Julie Rizzo, online.
I love Julie.
Oh, right on.
We all love Julie.
I love Julie. She's great.
Next gift card is a $50 Outback Steakhouse gift card from, oh, there's more. Bonefish Grill, Carrabba's, Fleming's. Dr. Gary Morris.
643. 643. Right on. Magic. Ooh, right on.
It's a $50 Sephora gift card from Eagle One. Winning person is Rain Levinson. I will give you, you'll mail that, but I'll give you the info when I have it.
As to who?
Is this all together like this? Trish, all together?
2 and 2, yeah, there's a.
Yeah, because I think everybody needs a
Yeah.
flask of this.
Alcohol, right?
Oh, I see.
That
I see.
helps.
Okay, so this is peanut butter whiskey and a flask in case you need to put it in your purse. From the IMA group, winning number is
627.
627. Peanut butter whiskey. Who's getting drunk?
I know it was you, Christina.
Yeah.
All
Yeah.
right, our next one is it yellow or blue?
Blue.
Is a $50 Amazon gift card with a cute little mug and some incense, maybe? No, what is that?
658.
From, sorry, Max Health. Max Health.
Movement lab.
It says it's battery powered, so I don't think it's instant.
I don't know
I'm
what
just
it
saying.
is.
I'm just saying. 658.
658.
Sue Hair. Okay, just for your note, it is not an infusion.
I know, I haven't got that yet. All right, our next one is
Can we do a yellow?
We're only two people
Yellow.
here.
$50 Cheesecake Factory gift card from Simon Medical Imaging. Winning person is Tracy That was Trish's. Yeah. $50 Yard House gift card from AMG Hospitals. Winning
629.
629.
629.
Yeah.
Dinah.
It helps when you buy a lot.
All right, whiskey lovers, we got another one. Peanut butter whiskey from Dr. Prober. All right. All right, there you go.
Yeah. He said I'm giving away whiskey. Nice.
631.
631.
Sounds like Christina Cruz.
Woohoo!
Wow.
That's what I'm
All
talking
the
about.
whiskey.
All the whiskey.
Go girl.
All the whiskey.
Double fisted.
I love it. I love it.
I know to get my husband to.
Right? The next one is a $50 Lazy Dog gift card from Dr. Andrew Park. Winning person, Myrna Corrales online. Next one is a $50 Amazon gift card from Dr. Rod Perry.
That'll cover my crack. 680. Not me.
680.
Christina Cruz, man.
Right on.
Damn, girl, what did you
Get
buy?
it, girl.
Yep.
The next one is a $50 Amazon gift card from me and my clients, but me. Dion Parker online. Next one is a $50 Macy's gift card from Max Health or the Movement Lab.
661.
661. Trish.
Even though you gave them all away, you still won.
All right. Our next one is a $50 gift card. It's got multiple things: gas,
Yeah,
Grubhub,
that's
Total
good.
Wine, Applebee's, Ulta. This is from Kelly Hawkins Physical Therapy.
674.
674.
74.
674.
Woo! Let's.
All right, you guys. Thank you
bought-
so much.
Oh, that's
for
it?
coming.
Woohoo!
Thank you. Awesome. That was awesome. I don't know if anybody heard that. Say it again.
What the f is this?
Say that again.
Please make sure you put your license number when you registered for this training. If you did
Oh.
not, please.
So what Trish is saying in the back of the room is make sure your license number is on your registration. If the last 2 times that you haven't had it, and you didn't put it on it, you can't get credit if you don't.
Also, if you want to look for 6-5 at June 5th and July 24th, make sure you got your CEU credits. If you did not, please send me or Trish an email.
Welcome aboard. Yeah, very nice to meet you.
Nice to meet you too. Love the hair.
Logan and David Pumpkins.
They need to be a member.
Yes, you need to be a member to have CEU